Ria, and Dr. Vinayak, MD FRCP. I would like to invite you, sir, for this session. Thank you for coming on stage, Dr. Nishant and Dr. Vinayak. And
Check one. Hello. Check one. Check.
Hello. Yeah. Good morning to everyone. Sunday morning. So the last day of the session, we'll have a great session on the first talk. I welcome Dr. Nishant sir and myself for this session. And today we are going to have a talk on orthostatic hypotension. So to talk on this session, uh, can I have some slides? नहीं सर उनका introductions ले तो yeah. So to talk on this, we have a very renowned mentor, great intellectual scholar, Dr. Vinod Abhichandani. He is just like a great mentor for us. We all know him from long time, so I think like we no need to give much of introduction about him. So uh, without wasting much of time, I call Dr. Vinod on the stage.
Is on. Slide changer if I can have. Anyway, honorable chairpersons and all esteemed colleagues, over next 18 to 20 minutes, I am trying to cover this important topic allotted to me, orthostatic hypotension. So that is good. ये on किया है? So orthostatic or postural hypotension is an excessive fall in blood pressure, that is when an upright position is assumed. The consensus definition is a drop of more than 20 millimeter mercury systolic or more than 10 millimeter mercury diastolic or both. Symptoms of faintness, lightheadedness, dizziness, confusion or blurred vision occur within seconds to a few minutes of standing and resolve rapidly on lying down. Some patients experience falls, syncope or even rarely generalized seizures. Orthostatic hypotension, I am going to briefly refer this to as OH, is a manifestation of abnormal BP regulation due to various conditions and not a specific disorder. Exercise or heavy meal may exacerbate symptoms, and most other symptoms, let's remember, are associated and related to the cause. I mean, they are in some way occurring due to the underlying cause. And OH has been associated with different mechanisms involved in CVD, starting from, I don't think this is taking up, okay. Starting from cardiovascular risk factors, including diabetes and hypertension, BP surges, heart rate variability, left ventricular hypertrophy, diastolic dysfunction, atherothrombosis and inflammation, MI, strokes, atrial fibrillation, arrhythmias, heart failure, through to end-stage heart disease or cardiovascular death. And besides the cardiac issues we notice, there are certain extracardiac disorders associated with CV autonomic dysfunction as represented by orthostatic hypotension. These include strokes, dementia, syncope, skull trauma, COPD, CKD, orthostatic hypercoagulability, and fragility fractures. And three types of OH have been described in literature. Neurogenic OH, which is the most debilitating and recurring condition. Primary autonomic degenerative disorders like Parkinson's disease, pure autonomic failure, multi-system atrophy, or peripheral autonomic disorders like immune-mediated neuropathies, inherited sensory autonomic neuropathies, inflammatory neuropathies, vitamin B12 deficiency, amyloid neuropathy, etc. are contributing, and they are associated with a low systemic vascular resistance state. When we come across cardiogenic OH, low cardiac output dominates, and we are likely to encounter persons with chronotropic insufficiency, heart failure, hypertension, volume loss secondary to dehydration, hemorrhage, reduced fluid intake, venous pooling, and amyloid cardiomyopathy. And then we have a mixed picture where both low cardiac output and low systemic vascular resistance will be encountered. Typically, this thing is seen, this particular type of OH is seen in diabetes, in CKD patients on dialysis, in amyloidosis, autoimmune diseases, aging, paraneoplastic syndromes, and drug-induced. So we'll be looking at a separate slide regarding the drugs which can aggravate OH. But at the bottom is, unfortunately, this is not working, the marker. Risk factors and modifiers of OH onset or recurrence, very, very important list. So they include bed rest, inactivity, deconditioning, large and or high carbohydrate meals, alcohol drinking, hot environment, prolonged orthostatic stress, morning hours after walking, initiation or intensification of antihypertensive treatment, and sleep disordered breathing. And this is a list of drugs that may cause or aggravate orthostatic hypotension. It's an exhaustive list, includes alpha blockers and antihypertensives under which diuretics, beta blockers, clonidine, long-acting CCBs have been implicated, antipsychotics, MAO inhibitors, narcotics like morphine, Parkinson's disease treatment, including levodopa and bromocriptine, PDI5 inhibitors, sildenafil, tadalafil, and vardenafil, TCAs like amitriptyline, nortriptyline, and vasodilators like hydralazine and nitrates. So what happens when a person rapidly stands up from a supine position, supine to active stand? And I would request all of you to have a good look. The red line denotes heart rate, that's beats per minute, and the gray bar denotes blood pressure. So in the classical orthostatic hypotension, the heart rate is hardly affected, and within 3 minutes, the blood pressure falls. In delayed orthostatic hypotension, that is B, heart rate again is only marginally, if at all, affected, but there is a drop in blood pressure after 3 minutes of active standing. In initial orthostatic hypotension, within 15 seconds, both, there is a major drop of systolic blood pressure, almost to the tune of 40 millimeter, or diastolic to the tune of 20 millimeter of mercury, and a small rise in heart rate, which rapidly resolves within 1 minute, within less than 60 seconds. And then we have vasovagal syncope. So after prodrome, there is a sudden drop in both the heart rate as well as the blood pressure. And till remedial measures are in place, this may continue and prove to be fatal occasionally. And the last differential diagnosis is a postural tachycardia syndrome, POTS, where the heart rate increases by 30 beats a minute or more. And this condition is typically seen in ladies 15 to 50 years of age, and the blood pressure may not be impacted. It may occasionally be slightly elevated or may drop, but in general, it's not majorly affected. Then coming to the treatment of orthostatic hypotension, the first and foremost is to modify the patient's review and modify the medication. So review of patient's medication, mainly antihypertensive agents, other vasoactive drugs, and antidepressants is called for. And we may choose to discontinue, replace, or reduce the dose. And lastly, we have to accept some higher levels of BP, especially in elderly, frail subjects, and don't pursue that aggressively. And non-pharmacological interventions include rapid intake of around 500 ml of water without any additive drink, avoidance of triggers like rapid standing up, standing motionless, hot environments, large meals, and prolonged bed rest. And it makes sense to increase water or salt intake throughout the day in such persons. Physical conditioning, that is some form of exercise, is beneficial. Physical counter pressure maneuvers are important. Head up tilt more than 10 degrees during sleep. This basically avoids supine hypertension and corrects the orthostatic hypotension. Elastic stockings and abdominal binding. Then the pharmacological interventions include FDA-approved drugs like midodrine, fludrocortisone, and droxidopa, and less established agents like pyridostigmine and atomoxetin, that is a norepinephrine reuptake inhibitor. And then there are other agents which may use for comorbid conditions when we suspect such comorbid conditions to be contributing to OH. They include erythropoietin in case of anemia, desmopressin in case of nocturnal polyuria. This is available as a spray or as an oral agent. Octreotide, somatostatin analog for postprandial OH, and acarbose again for some cases of postprandial OH. And we can choose to combine therapies from this basket. Now, a few slides pertaining to the tilt test. A tilt table test is a diagnostic procedure for patients with syncope of unknown origin. Today, a tilt table test is believed to reveal susceptibility to reflex hypotension rather than the cause of the syncope. A negative result tilt table test is characterized by a moderate increase in heart rate and the maintaining of the systolic blood pressure above 90 millimeter mercury without symptoms during the planned duration of the study. However, some other positives can be inferred, we may pick up and distinguish between initial orthostatic hypotension, classic orthostatic hypotension, delayed orthostatic hypotension, and the POTS syndrome. And patients may present chronotropic incompetence when their heart rate does not increase more than 5 minutes above baseline values. Now I present honorable chairpersons and all esteemed colleagues. I am going to present two cases from my humble clinical practice before I end up my presentation. The first one, a 61-year-old woman presented with a 9-year history of lightheadedness when standing still or after climbing stairs, which was relieved by sitting or lying down. She reported heat intolerance and urinary retention with occasional incontinence beginning almost 7 years earlier, and this was managed herself by intermittent self-catheterization. Her medical history otherwise was unremarkable, and she was not taking any regular medications. Neurological examination was normal. Cardiac evaluation revealed mild chronotropic incompetence, but no structural abnormalities. A tilt table test reproduced her typical symptoms within 3 minutes, coinciding with a progressive decrease in blood pressure from a high of 159/112 supine to 85/71 when fully tilted, but only accompanied by a mild increase in heart rate from 62 beats per minute supine to 70 beats per minute tilted. So the severe orthostatic hypotension and mild increase in heart rate combined with reduced heart rate variability during deep breathing and absence of a blood pressure overshoot during the Valsalva maneuver confirmed neurogenic orthostatic hypotension. And when we were conversing with her, we found that this smart lady had devised for herself some counter maneuvers, including tensing of her abdominal and gluteal muscles, and these were proving effective for her and relieving her symptoms. Additionally, she used bolus water drinking in advance of triggers like standing long time during social events, and taught herself to stand up gradually. She raised the head of her bed 20% to reduce supine hypertension and improve orthostatic hypotension. And these are some physical counter maneuvers which are likely to benefit all patients with orthostatic hypotension. They include crossing the legs, placing a foot on a chair or a stool, squatting when standing, and crossing the legs while seated. Over time, her lightheadedness worsened, and treatment with fludrocortisone 0.05 milligram per day and midodrine 5 milligram 3 times per day was started. Although fludrocortisone was kept at a stable dose, she was allowed to manipulate her midodrine as needed, as her symptoms varied. Mild symptoms during winter while at home, but severe symptoms on hot summer days or when she was more physically active. And this is a recap of what I have already referred to. I am not going to halt here, but it gives us the drug name, mode of action, and side effects. Now I come to my second case. A 72-year-old man was referred for loop recorder, which is basically a small gadget which records our rhythm and rate continuously. It can record up to 3 years long battery life. So this particular elderly citizen was referred for loop recorder to evaluate syncope. Syncope would occur only while standing, but the timing was variable, often occurring after several minutes of standing. And luckily, the events were brief, lasting several seconds only, and there was a rapid recovery of his consciousness. And he was suffering from Parkinson's disease and was on levodopa. His supine BP read 170/82, and heart rate was at 70 beats per minute. After standing for 5 minutes, the heart rate remained the same, but the BP dropped to a low of 90/50 millimeter mercury. And this is a schematic presentation of the same phenomenon. Unfortunately, this is not working. It should be a anyway, the supine hypertension on the left side of the cartoon, you can see the supine hypertension at baseline. And following the head up tilt, there was HUT. There was progressive hypertension without significant heart rate. This is okay. This is there. Okay. Changer. I'll have to hold both. So this is it. I was looking out for this. So basically, this is a systolic, diastolic, and the straight line is the heart rate. And you can see supine hypertension at baseline, and following the HUT, there was progressive hypertension without any significant heart rate response. And during strain phase of Valsalva on the right side of the cartoon, the maneuver, there was significant drop in the blood pressure with no associated increase in heart rate. Heart rate remained the same. So levodopa we can suspect might be contributing to this patient's agony, but it was required for Parkinson's disease and we could not discontinue it. Dosing time, we offered the patient midodrine 5 milligram every 4 hourly, 3 times a day, and we kept the timing at 8 a.m. Technology has its own vices and virtues. Vice we are experiencing. क्या करें? Okay. ठीक है. So we might be suspecting levodopa to be a culprit, but we needed to continue with that medicine. And then we offered midodrine 5 milligram every 4 hourly, 3 times a day. We chose 8 a.m., noon, and 4 p.m. as the timings to cover the active period. And this resulted in decreased syncope during follow-up. History, physical examination, and ECG are the only investigations for syncope strongly recommended by guidelines. And syncope after prolonged standing, pre-syncope with stress and fatigue during recovery are, thank you for that, are associated with vasovagal syncope. And there is a reference at the bottom. You can see the reference, 2017 reference. Orthostatic vital signs are critical to identify neurogenic OH. And this is another important reference. Again, I believe this is a 2017 reference. And the authors that tested sit-to-stand test. And sit-to-stand assessment of orthostatic vitals can be used with drops of more than or equal to 15/7 systolic diastolic millimeter mercury considered significant. So this is another important takeaway for all of us. Second last slide. So cardiovascular autonomic testing is the gold standard for diagnosing NOH. And typical findings of NOH include when we do head-up tilt, rapid and sustained hypotension with lack of compensatory tachycardia, and when we make the patient go for a Valsalva maneuver, progressive hypotension during sustained strain will be observed with a slow return to baseline blood pressure post-release without a blood pressure overshoot. So the learning points are that neurogenic orthostatic hypotension, which is a very common and lingering phenomenon, recurring phenomenon, can cause syncope. Diagnosing NOH requires an organized approach to history and physical examination. And measuring orthostatic vital signs is cost-effective and critical to diagnose neurogenic OH and all types of OH. Thank you very much for your patient hearing. And
thank you, sir. Thank you for lucid presentation.
Yeah. If there are any questions, comments, criticism, everything is welcome. So.
The questions are open for the session. Yeah, at the back.
Ji, sir. He needs a mic. Yeah. Okay, you can. I'll come down on this side. Yeah, I can. I mean, you are an ex-army man. I am sure you are having a very robust voice.
Sir, excellent presentation. Only one submission, sir. I think in the list of the drugs, we are using SGLT2 inhibitors quite a lot. So I think that needs to addition.
Yeah, so, it theoretically, and I have a very learned endocrinologist and all the stalwarts here, pandas are here. So let me also, expand and throw this question to the podium and have their opinion also. In my humble opinion, SGLT2 inhibitors in the given dosages, in the appropriately selected patients, does not cause hypovolemia of any major degree. which would induce orthostatic hypotension. But if the patient has a history of orthostatic hypotension, and we have to make sure he remains euvolemic, and at the start there is a, diuresis type of effect, which wanes over a period of maybe couple of
Our,
weeks.
like in Visakhapatnam here, on some part of Orissa, where tropical climate, the temperature charges 45 degree in the summer. That time we have experienced many of our patients on
Develop-
SGLT2 inhibitor. Last 3-4 years we are observing. It starts around, and
I-
that time sometime we even reduce or stop the dose.
Even at Ahmedabad, from where I do come, things are very hot. So we have patients, occasional patients suffering that. But let's have Professor Panda's opinion on this, final opinion.
Yeah, this is a very
Common.
interesting field. We usually accept that SGLT2 inhibitors doesn't
Cause.
cause orthostatic hypotension, because that is taken.
I think it is accepted now
Yeah, yeah.
that in the given dosages and in the properly selected patient. If I go for a frail, dehydrated patient, I am going to invite maybe euglycemic decay rather than orthostatic hypotension. So,
Just quoting a case study, one of a senior diabetologist from Bhubaneswar, many of you know him, Dr. Alok Kanungo.
yeah.
He had vertigo, persistent vertigo, for last 6 months. So we evaluated all possible causes, we didn't get. So we did a Hoot state, that tilting the bed
Yeah.
and recording the blood pressure. and
head up
blood-
tilt.
Yeah, head up tiltable, and the blood pressure came down to 60/30. So there is significant orthostatic
Orthostatic
hypotension.
hypotension, yeah.
That was the cause of vertigo. And after stopping his empagliflozin, he is fine now for last 10 days.
Yeah, so there may be one-off
Yeah,
such
yeah.
cases, but in general, let's say out of 10, I would say none. Out of 100, maybe 1 or 2. Do you agree, Dr. Vinayak and Honorable Sir? Do you agree?
Because he's an exceptional case I quoted. My opinion is it's not a common cause of orthostatic hypotension.
Hypertension.
But anybody on the drug or anybody
On diuretic, loop diuretics के साथ दे.
They have.
अगर suppose heart failure में many cardiologists are now using even in non-diabetic. Let's forget about diabetic population. So in those cases, loop diuretics are the major culprits for inviting orthostatic
If
hypotension.
somebody is on a cocktail, you have to be careful
Yeah, close.
regarding the possibility.
Yeah, due to we are running out of time, sir.
Yes,
Thank you.
thank you so
That was
much.
a great session.
Thank you,
Thank you for teaching us once again. So,
For the next speaker,
Th-
Dr.
Thank you. Thank you, Vinayak sir. So for the next session, I would like to invite Dr. Ajay Tiwari, well-renowned diabetologist of Lucknow, UP Secretary, RSSDI. So Dr. Nishant and Dr. Ajay Tiwari will chair the next session. And for the speaker for the next session is Dr. S.K. Gautam. Kindly introduce the speaker.
Hello, a warm good morning to all of you. And the next speaker is Professor Dr. S.K. Gautam. He's an MD Medicine, FICP, FIACM, FACP, FINSH, Professor of Medicine, GSVM Medical College, Kanpur. He's an ex-registrar, Medicine, Maulana Azad Medical College, New Delhi, Fellow of American College of Physicians, Fellow of Indian College of Physicians, Fellow of Indian Association of Clinical Medicine, Fellow of Indian Society of Hypertension, and he was the organizing secretary of UP Epicon 2021. And is the honorary secretary of API Kanpur branch, governing body member API UP chapter, life member of so many organizations, and is a very eminent speaker. So much and time constraints, I would request Dr. Gautam to start his program.
स्लाइड चेंज स्लाइड चेंज करने के लिए कौन सा ठीक है पॉइंटिंग जरूरत गुड मॉर्निंग एवरीवन सो थैंक यू चेयरपर्सन फॉर द काइंड इंट्रोडक्शन so before start my talk I must compliment the organizing committee for a wonderful organization of this conference. Especially thankful to Dr. Anuj sir and Dr. Narsingh Verma sir for inviting me here and to share the dais. So in the next 18 to 20 minutes, I will be speaking on the topic management of acute variceal bleeding. It's a very common topic we physician deal oftenly these cases, and if you promptly diagnosis and the prompt management can save the life. Otherwise, mortality are very high with the acute variceal bleeding. So, start from the basics. So, if you see upper GI bleeding is usually defined as the bleeding source proximal to the ligament of Treach, and it is usually a life-threatening conditions. And the upper GI bleeding emergencies are characterized by certain things like hematemesis, melena, hematochezia. Hematemesis is a fresh blood orally is proximal to the ligament Treach. If you talk about the melena, melena is not basically a black color. It's a black tarry color stool, basically offensive in smell and sticking to the pan. This is a characteristic of the melena, usually present with the melena in upper GI bleed. Third one is the hematochezia. Hematochezia is basically a fresh blood per rectum. So hematochezia usually occur in the cases of lower GI bleed, but in upper GI bleed, if patient is having the massive upper GI bleed, patient can manifest in the form of hematochezia. In that case, the patient will be hemodynamically very unstable. So, and last is the patient can present in the form of occult blood also. So, coming to the incidence of upper GI bleed. So, incidence of upper GI bleed is approximately 100 cases per 1 lakh of the population. So, bleeding from the upper GI tract is approximately 4 times more common than the lower GI bleed, and it's a major cause of mortality and morbidity. So mortality rates from upper GI bleeds are ranging from 3 to 15% and increases with the age. These are the potential sources of upper GI bleed. If you talk about the Indian scenario, the most common is the portal hypertension, variceal bleeds around 46%, pet ulcer diseases like 32%, Mallory Weis-Trier is around 6 to 8%. And if you see around 2.8% cases, we do not find any identifiable cause. So obscure bleeding is there. You have to search for the cause. Coming to the risk factor, what are the potential risk factors for upper GI bleed in which the mortality and morbidity are high? Age is more than 60, severe comorbidities, active bleeding in the form of melena, hematochezia, or hematemesis, hypertension, blood transfusion, more transfusion required, inpatient and time of bleeding, severe coagulopathy, and patient is presented with a hemorrhagic shock. So these are the factors which are having high mortality in upper GI bleed. Now come to the how to evaluate a patient. So initial assessment, brief history and symptoms, then physical examination and laboratory workup. Initial assessment is very important because here we have to assess whether your patient is hemodynamically stable or unstable because the management are different. So, before we have to confirm the cause clinically first. We are talking about the basics in this conference, back to basics. So basic history is the basic. We have to find out a basic cause for bleed, whether it is a variceal bleed or it's a non-variceal bleed. So by history, if a variceal bleed is there, you can get a history of jaundice, liver diseases like excessive alcohol intake history. Will suspect the portal hypertension, variceal bleed. A patient is having history of H. pylori in the past, and the NSAID chronic use uneven alcohol can cause the peptic ulcer disease. And in angiodysplasia, there's a history of aortic stenosis and hereditary hemorrhagic telangiectasia that we can suspect the angiodysplasia. So these are the common symptoms like upper abdominal pain, nausea, vomiting occur in the peptic ulcer disease. If we suspect the variceal bleed, we can have a history of jaundice and then yellowish discoloration. And then on examination, we can find the clinical finding relevant to the chronic liver disease or portal hypertension. So vital assessment is a critical part of the examination and key component to assess the hemodynamically stable or unstable patient. BP is less than 100 mmHg and tachycardia more than 120 mmHg suggests the hemodynamically compromised and warrant the fluid resuscitation and blood transfusion are urgent is required. SpO2 to be measured, supplement oxygen if needed, and patient may complain of giddiness, sweating, palpitation, and may become a drowsy because of the hemodynamically compromised states. vital assessment, the patient is having a resting tachycardia, means the patient is having bleeding, more than 15% blood loss is there. Patient is having orthostatic hypertension, as in previous talks, sir has nicely elaborated this orthostatic hypertension. So in that case, patient is having the bleeding loss is more than 15%, but patient is having the supine hypertension, then the much loss of blood is much more, it's around 40%. So we can assess by vital assessment. By abdominal examination, we can have a look for the cause. What are the causes of the quick abdominal examination, like a patient, we suspect the varicose bleed. We have, will have the signs of chronic liver disease like ascitic, splenomegaly, then parotid swelling or testicular atrophy or copper bed. So these are the signs we can get, and we can suspect it's a variceal bleeding. So upper GI bleed without ascites or splenomegaly usually indicates a non-variceal cause. So now come to the workup. So these are the routine investigations: CBC, LFT, KFT, ABG, and serum electrolyte, prothrombin timer. The basic initial investigation we have to send immediately. In acute bleeding, initially HB will not drop. It will not drop, and because the patient is losing whole blood and within time. Blood is diluted by influx of the extravascular fluid, and hemoglobin is dropped down. So in acute bleeding, MCV does not alter. If MCV is low, we can suspect chronic blood loss, history of chronic blood loss, or occult blood will be there. Blood urea, nitrogen to creatinine or urea to creatinine ratio, the value will be more than 30:1 or more than 100:1 respectively seen in the upper GI bleed. So now come to the resuscitations. In initial management depend how your patient is stable or unstable. Closely monitoring the airway, vital signs, cardiac rhythm, urine output, and a patient keep patient nil orally, gastric lavage done to just confirm the bleeding and supplement oxygen to be given. So if patient is unstable, we have to maintain ABC, airway, breathing, circulation, and disabilities. Airway needs to be secure if patient is altered, GC is lower than 18. Breathing, oxygen supplement by mask or ET tube. Circulation, immediately we have to put the 2 large cannula, at least 18 gauge are secured, and we have to steroid the crystallite solution 10 ml per kg bolus, and we'll repeat 3 times. If patient is still unstable, we can go for the transfusion. And in case of hemodynamically instability, at least 2 units of PRBC is required. Now, we have to look for the disabilities also, like hypos or hyperglycemia or hyponatremia. We should manage this disability accordingly. So indication of blood transfusion in upper GI bleed or acute variceal bleed. In case of hemodynamically unstable, straightforward go for the at least 2 units of PRBCs. But if patient is stable, the threshold of a transfusion is less than 7 gram in adult and less than 8 gram in old ages, and less than 8 gram in a patient having the history of CAD. If a massive large amount of PRBC is required, the platelet FFP is also given. The ratio of PRBC platelet FFP are given in 1:1 ratio to avoid the dilutional coagulopathy. Avoid overtransfusion in case of acute variceal bleed. So these are the specific treatment for the acute variceal bleed. Acid suppression by proton pump inhibitor. Immediately we have to start with the pantoprazole infusion, IV infusion at 80 milligram bolus to be given, and then followed by 8 milligram per hour infusion. And PPI as a pre-endoscopic therapy is considered as a good treatment because it's probably delay the endoscopic therapy, and PPI may improve the outcome also. Prokinetic, role of prokinetic is before endoscopy we have to clear the field, to visualize the field for endoscopy. So prokinetic is required. Vasoactive medications, somatostatin and analog octreotide, then terlipressin are mainly used in the treatment of variceal bleed, and this can reduce the risk of bleeding due to the non-variceal cause also. So, and antibiotics, IV ceftriaxone or fluoroquinolones are given at least 5 to 7 days to decrease the chances of spontaneous bacterial peritonitis. And it's also decreased the patient go into the hepatic encephalopathy. Injection vitamin K to be given to combat the coagulopathy, and the no role of tranexamic acid in the cases of variceal bleed. These are the drug medical therapy we usually go for in variceal bleed, octreotide or terlipressin. Many times a question start arising whether you go for the octreotide or terlipressin. So literature and most of the studies shows both are equally effective. These are the differences. Somatostatins analog, octreotide is a somatostatin analog, effective in the acute variceal bleed. It is FDA approved, cost effective, and safer and lesser side effect as compared to the terlipressin. If you talk about the terlipressin is basically a potent splanchnic vasoconstrictor. So it has a side effect also. Highly effective, but it's not US FDA approved. It's a costly and need specialist to be infused. And the common side effects is that basically causes the, if it's a vasoconstrictor, so it can cause the coronary constriction, mesenteric constriction, so can cause, precipitate the MI, so we should avoid in the cases of coronary artery diseases, and it causes the mesenteric ischemia also. So these are the side effects we have to take care of that before giving the terlipressin. And if a hyponatremia is there, we should avoid the terlipressin. So, and it should be avoided in asthma and COPD also. Coagulopathy, antiplatelet and anticoagulant should be held at the time of active bleeding, and the PT-INR should be calculated. Duration of the hold of these drugs depend which type of drug, what severity of the bleeding is there, and how quickly we reverse this drug is required. So endoscopy should not be delayed because of the antiplatelet or anticoagulant patient is on. So usually we have to keep the INR less than 2.5, but it's a safe procedure and urgent FFP transfusion done along with the injection vitamin K if it is INR is on higher side. But various studies shows that the endoscopy is safe, effective in patients who are mild to moderate anticoagulated. So we have, without any delay, we have to go for the endoscopic procedures. So these are the EV endoscopic variceal ligation and secondary prophylaxis for the best to prove the rebleed. So if a patient, endoscopy procedure, we have to go for the endoscopic variceal ligation done. If bleeding is not controlled, then we'll go for the repeat endoscopy. If bleeding is controlled, then we'll go for the secondary prophylaxis in the form of beta blocker. And it's not controlled, then we plan for TIPS, and before TIPS, we can occlude by balloon tamponade. Prophylaxis by using the beta blocker. So it's a non-selective beta blocker, block the beta-2 mediated dilatation of the mesenteric arterioles, resulting in the vasoconstriction and subsequently decrease the portal blood flow. So the main aim of the propranolol is to keep the HVPG is below 12 mmHg to prevent the re-rupture of the varices. Prophylaxis can be primary or secondary. Primary means there's no bleeding was there. Secondary, it is after the first episode of the bleeding. So if no history of bleeding, still the primary prophylaxis for the beta blocker is required if it is at grade 2 or 3. But it is in grade 1, small varices are there. Prophylaxis for beta blocker is not required in the grade small varices until patient is in a Child-Pugh score B or C. Secondary, we have to give the beta blockers, but in certain cases we have to very cautious. If hypertension is there, hyponatremia is there, AKI and refractory ascites, we should very careful for giving the beta blockers. These are the Baveno consensus guideline on portal hypertension. The workshop was entitled as the satisfying risk and individualizing the care of portal hypertension. So various points were discussed in that workshop regarding the impact of the etiological therapy for cirrhosis and primary prevention for decompensation, role of beta blocker for prophylaxis, management of the acute bleeding episodes, and prevention of the recurrent hemorrhage and other decompensating events. So consensus on the beta blocker. Beta blocker started on the basis of HVPG, and the aim is to keep below 12, which is clinically significant, because above 12 is a clinically significant portal hypertension, so we have to keep it below 12 or below 10. So in various patients with no varices or small varices, there's no role except in Child-Pugh score C. Varices size are medium or large, we we have to go for the beta blocker, non-selective beta block will be used. A patient is having the gastric varices. In gastric varices, we have to go for the cyanoacrylate injection therapy. It's more effective than the prevention with the beta blocker. And the bleeding in the end-stage liver disease, refractory ascites, we have to take care of giving the beta blockers. So these are the window hypothesis in which early cirrhosis, when there's no indication of beta blocker, and only beta blocker may be indicated when there is cardiovascular involvement. But in the cirrhotic patient, window opens, beta blocker are indicated here in the primary as well as the secondary prophylaxis to prevent the bleed. Window closed. These are the contraindication of giving, or we should very cautious about giving the beta blocker, like in the refractory ascites, systolic blood pressure less than 100 milligram, 100 mmHg, AKI is hepatorenal syndrome, spontaneous bacterial peritonitis, sepsis, poor medical follow-up, and patient is non-compliant. So we have to take care of giving the beta blockers. So by managing the acute episode, our target of the hemoglobin is around 7 to 8. More transfusion should not be required because at that time patient is bleeding. If you give the over-transfusion, patient bleeding can increase. To prevent the systolic blood pressure, complication of acute bleeding episode, antibiotic prophylaxis, then vasoactive drug, I have already explained, ligation therapy. If a patient is having the gastric varices where glue is recommended, and early consideration of TIPS is done. If bleeding is not stopped, then EVL, in spite of giving the EVL and the beta blocker, then plan for the TIPS or balloon tamponade. These are the tamponade we are using. Endoscopy, so early endoscopic therapy is recommended for the patient with acute variceal bleed. These are the algorithms for the management of variceal bleed, resuscitation, then medical management, endoscopic service if not available, then you continue the medical management. Patient is still bleeding, then you go for the balloon tamponade and try to transfer the patient to higher centers. Endoscopy is there, you go for the EVL. In gastric varices, you go for the glue injection, cyanoacrylate glue. So these are the techniques which can use for the esophageal varices and gastric varices. We are using the endovascular ligation and the glue therapy. Some scoring system are there to just see the prognosis and mortality of the or rebleed in the patient, like SCOL score, Glasgow-Berthold score, and Ames score. And these are the Rockwell score, the clinical and the endoscopic parameters are there. And then Glasgow-Berthold score, total Glasgow-Berthold is around 0 to 23. Score is 0 is associated with a low risk and need of endoscopy. Ames 65, again, scoring is not very much sensitive than other two. So we assess. So just here, I summarize my talk. Acute variceal bleed is a potentially life-threatening and if not intervene timely. And endoscopy is the main modality of diagnosis and management of acute variceal bleed. Initial assessment is crucial in predicting the rebleed and the mortality. Combination of the medical management, injection, thermal, mechanical method give better results, and novel modalities such as OT clips and the use procedures may replace other method in future. Thank you. Thank you so much for the patience hearing.
Excellent talk, Professor Gautam, and I think you have covered almost all aspects of variceal bleeding, and I think we should be going on for the next session because we are running short of time and we have to do the felicitations also. So I would request the moderator to kindly call the next speaker.
Hello, very good morning to one and all gathered here. For the next session, for chairing, I would like to invite Dr. Khan Abdul Kalam. If present, please come on podium. Dr. Pranav Kabra. I think he is not here. So I would like to request Dr. Vijay Kumar Chaudhary, Professor, Department of Medicine, Fatehpur Medical College. Sir, please come on dais. Dr. C.L. Naval, Professor, Department of Medicine, SMS Medical College, Jaipur. He is MD, FRCP, FACP. Sir, please come on dais. So I would like to request chairperson, kindly invite the next speaker, please.
Now, without delaying, now directly calling or inviting Dr. Jayant Panda. He is professor and head, PG Department of Medicine, SB Medical College, Cuttack, Odisha, MBBS, MD in Internal Medicine, FICP, FACP, FIMAMS, FRSSDI Fellow, National President, CCDSI, Chairman, API, and Governing Body Member, Organizing Secretary, RSDI, Member Advisory Council of Governor ACP, Member CWCIMA, 71 national and international publication, Principal Investigator of Internal and National Trials. So, over to Dr. Panda. Now, stage is yours. Over
Thank
to
you.
Dr. Panda.
Thank you, sir, for those nice words. I must thank Dr. Anuj Maheshwari, my good friend, and the whole team of ACP India chapter and the organizing team of this Visakhapatnam ACP, which has been marvelously conducted, excellent academics, good hospitality, and we have been enjoying here, and this will be a landmark conference in the history. My topic is obesity and the Alzheimer's disease, minimizing the risk. As all of you know, this is a less ventured topic. We don't know much about Alzheimer, and that to how obesity is linked to Alzheimer. So what I want to share you that the metabolic problems are gradually expanding its grip, and Alzheimer's disease and the dementia have come to the center stage. So we know that Alzheimer's disease is a progressive neurodegenerative disease, and approximately 33 to 44 million people worldwide are affected in this disease. The important is approximately 75 million people, more than 60 years, have Alzheimer's in the minimal cognitive impairment stage, which is known as MCI stage. And the number of people living with Alzheimer's disease is increasing due to aging population. We have more people surviving, and elderly people, and more of them are having Alzheimer's. And this Alzheimer's causes progressive cognitive impairment, including memory loss, functional decline, and the behavioral symptoms. The patients develop progressive difficulty performing daily activities and become increasingly dependent on the care partners. It's associated with significant morbidity and poor quality of life, and is ultimately fatal. You know, many senior citizens, many celebrities, many respected people have suffered and who have lost their service for the country because of this disease. The dementia and the minimal cognitive impairment can be caused by many different etiologies, which all of you know. It can be because of the toxins, alcohol, which is so commonly consumed, can be a cause of Alzheimer's. The detergents, the heavy metals, infections like Creutzfeldt-Jakob disease, HIV, syphilis, and herpes, and the space-occupying lesions like tumors, normal pressure hydrocephalus, and the hygroma are in the list. Many people develop stroke. We know the number of patients with stroke in our hospitals, maybe infarction or hemorrhage, and both of them, because of the vascular causes, can cause Alzheimer's and dementia. And the Alzheimer's disease per se is 60 to 80% of this all causes of dementia, and extracellular deposition of the AB plaques and the intracellular neurofibrillary tangles in the brain are the most important finding which diagnoses this disease. The dementia with Lewy bodies and the Parkinson's disease dementia, where we get the neuronal inclusions composed of a alpha-synuclein protein and the aggregate that promote death of a dopaminergic neuron, is a basic pathophysiology which causes the problem. And the frontotemporal dementia, where the heterogeneous spectrum of the brain disorders affecting the frontal and the temporal lobes, the neuropathological inclusions are tau proteins that you have read in your book, and the TDP43 or FUS ubiquinated proteins are the pathology. So I'll tell you the number, how the load is there in the society. The estimated number of people living with Alzheimer's disease per disease stage. There are many people who are in the preclinical Alzheimer's who are normal cognitive function. You cannot detect them as a impaired cognitive function. There are the mild cognitive impairment due to Alzheimer, also referred as prodromal Alzheimer. There are around 60 million, and they have the mild cognitive impairment because of the Alzheimer. And the disease per se is classified in mild, moderate, and the severe. And this number is around 37 million, as I have already mentioned. So we have around 37 million people worldwide with Alzheimer, and 60 million people worldwide with minimal cognitive impairment. Whole around 100 million patients are there living with Alzheimer's disease worldwide, excluding the preclinical who are likely to become clinical within 2 years of time. So how obesity is related to Alzheimer? You must be wondering. We know obesity with diabetes, hypertension, dyslipidemia, osteoarthritis, gallstones, cancers, and then many diseases. But why Alzheimer and obesity is linked? The obesity problem is also increasing, that all of you know. We had a beautiful session on the obesity yesterday evening. Dr. Jyotidev conducted it nicely, and the message was given about the metabolic challenge. Around 650 million people live with obesity in the world now. And the prevalence is increasing day by day. And in India, the statistics are alarming, and number of adults with obesity are around 2 crore or around 20 million now, which are likely to increase to 6 crore or 60 million in 20 years' time. So we are projecting a 300% increase in the number, and India at 99th rank in the global preparedness with US dollar 23 billion economic impact of the obesity in India in 2019, and 10.8% annual increase in the childhood obesity. You go to any affluent school, you'll find around 1/3 of the children obese. This is a very important slide, which I'll take a minute of yours. The clinical study is showing an association between obesity and the cognitive impairment. So you can see here, there are many studies with different number of patients in different countries like USA, France, UK, Sweden. They have studied the young people, the middle-aged people, and the elderly people. They are taken as a different age group, and the observations, the cognitive tests were done, who were all having high BMI, and the observations ranged from adverse cognitive effect to the frank dementia. And obesity associated with all cognitive impairment, and mostly men were affected and female were less affected. And here in the Connaught et al. Study in France, the cross-sectional analysis showed the participants with higher BMI had lower cognitive scores. Prospective analysis showed a higher BMI predicted a higher cognitive decline. So there is a direct relation of BMI with the cognitive decline. So bigger is the belt size, lower is the mental alertness to a problem that you can take for granted. So all the studies show the cumulative effect on the obesity in the cognition, and overweight in the midlife was associated with lower overall cognitive function in the old days. That's a very important fact. Those who are obese in the children, those who are obese in the midlife, those who are obese in the elderly. So those who gained weight in the elderlyhood were not much affected by the problem. but those who were obese in the midlife, they were only seen to have an increased risk of cognitive dysfunction. So overweight or the obesity in early midlife predicted the low cognitive function and cognitive decline in the late life. And that message here from all these studies, two clear messages I'll give you. One is the BMI is directly related to cognitive decline, and the women are less affected than the men, and in the midlife increase in the obesity is directly related to the menace of Alzheimer's disease or the dementia. So looking to the structural changes in the brain due to obesity, the mild cognitive impairment in Alzheimer might have a consequence of structural change in the brain and the decreased cerebral integrity. In the patients with obesity or the metabolic syndrome, there is evidence of decreased hippocampal volume as well. And then you can see this publication of 24-year follow-up of the body mass index and the cerebral atrophy, where women with atrophy of the temporal lobe were on average 1.1 to 1.5 kg meter square higher BMI, which I told you, higher the BMI and higher the atrophy, and more is the cognitive impairment. And neurological consequence of obesity through free fatty acid are still interesting. You can see the CNS and PNS are detrimentally affected by the obesity and the obesity-induced metabolic dysfunction, driven by lipotoxic effects and the dyslipidemia and increased circulating free fatty acid. So in the CNS dysfunction leading to the mild cognitive impairment and eventually Alzheimer's disease, this is very important. So this is what the dyslipidemia and the Alzheimer is related. So this is all a cluster. Obesity causes dyslipidemia, dyslipidemia causing Alzheimer's. And the neurological consequences of obesity through the leptin and adiponectin are two important hormones that we'll see before we go to the concluding part. Leptin is secreted by the adipose tissue, which matter for the correct functioning of the brain, including the memory, the learning process in the hippocampus. And the leptin enhances the LTP and decreases the LTD, thereby increasing the efficacy of excitatory synaptic transmission. So it enhances the removal of A-beta by promoting its clearance and the degradation and the activating the insulin degrading enzyme. So the very important thing, there is an inverse relation. So more is the leptin, more is the less is the chance of Alzheimer's, and if there is a leptin resistance or decrease in the leptin level, there is a chance of Alzheimer's or dementia more. And the leptin resistance, normally NMDA signaling and the leptin receptors signal MORS, exerting the neuroprotective effect in the cells. On the other hand, the leptin resistance impairs this pathway that could promote the apoptosis and the cell death. The neurological consequence through adiponectin is still interesting. More is the adiponectin, more is the leptin, better is the memory. Less is the leptin, worse is the memory. But adiponectin has an inverse relationship. This is released by the adipose tissue again. It has been found to modulate some brain function like memory to produce the neuroprotective effect on the hippocampal neurons. And the adiponectin levels are inversely associated with the insulin resistance, obesity, and the type 2 diabetes, as well as the Alzheimer's disease. The mechanism involving adiponectin in the brain are still unclear, but epidemiological studies have reported that both Alzheimer's and diabetes, the plasma adiponectin levels are significantly lower than the healthy individual. So by assessing the adiponectin, by assessing the leptin, we can know the risk of this obesity causing dementia or Alzheimer. The neurological consequences of obesity through the additional mechanisms include the member of neurotrophin family, and this is also expressed in the adult neuron in the high levels of through the CNS, and they reported in the obesity. The low level of BDNF have been related to many diseases such as Alzheimer's. And the adipokines related to the vascular health, the platelet activating inhibitor, and they are involved in the cell migrations and related to learning and memory process. And the AGT is produced by the liver and the white adipocyte tissue in the order to increase the blood pressure, and an increase in AGT has been reported in the obesity and considered as a risk factor for the AD. So these are all proved facts, and so many links are there by established relating the obesity, dyslipidemia, and the Alzheimer's disease, and the dementia. And the important message which I want to give you is the age of obesity is important. So the dangerous trend is the children or the midlife aging, which are invariably causing the late life dementia or the Alzheimer's disease. Those who gain weight late in life, they are not affected. And it proved beyond doubt. The relation between BMI and dementia among people over 65 is controversial. So both overweight and obesity at midlife independently increase the risk of dementia, Alzheimer's, and vascular dementia. Genetics and the early life environmental factors contribute the midlife high adiposity dementia associations. So this has been proved beyond doubt in multiple studies. And the benefit of lifestyle, because our topic is how to limit this obesity, how to limit this Alzheimer's. So benefit of lifestyle intervention on neurological complications are very important, and I am quoting a series of studies. The obesity and dyslipidemia, I told, are linked. They can provoke highly morbid neurological consequences like optimal therapy, and it is to be to target the obesity itself. So the lifestyle modifications, alcohol moderation, regular exercise, proper diet, reduction of the stress, all have been studied very positively, decreasing the risk of Alzheimer's in obesity. So to summarize, the Alzheimer's disease is a progressive neurodegenerative disease and the most common type of dementia. Almost 70% patients of dementia are suffering from Alzheimer's, which has been histopathologically proved. There is currently no cure for Alzheimer's disease, and no one recently approved treatment targeting the underlying cause of the disease are available. That it's highly unsatisfactory to deal with such patients. And we have clear evidence that the lifestyle disorders like obesity, the metabolic disorders like dyslipidemia are a part of the cluster which worsen the metabolic control and expose the person to the possibility of Alzheimer's or dementia. Obesity, especially at the midlife, has the detrimental effects and promotes Alzheimer's disease through the various mechanisms. So ladies should be happy that they have less risk, but those who have obesity or weight gain are equally exposed to the dementia. And more important is this age, it's all our age where we are gaining the BMI and at risk of developing the complication. So the evidence shows that the cognitive function improves by the targeting obesity. So it's not that the cause and effect relationship is there. By controlling the obesity, we have got less prevalence of Alzheimer's disease, and also the reversal of cognitive impairment has been reported. So during your assessment, you have to assess obesity of all the people, and along with the existing risks which you are discussing, like diabetes, hypertension, dyslipidemia, cancers, osteoarthritis, you have to add another risk factor related to the overweight and the obesity. Thank you again for the opportunity to speak you all in this prestigious conference, and I'll be happy to take up questions if any.
Thank you, Dr. Jayant Panda. So nicely narrated by you. This neglected topic made interesting by you. And if there is any question, okay, then that is speaking to next speaker.
Thank you. Thank you.
Yes, please, go ahead. Dr. Panda, one question is there for you.
Yeah. Actually,
One question.
I was really very happy to note that the obesity is really a concern. Only just I was thinking on the retrospect, we had Professor Panda, who is my classmate also, and I'm really very thankful that we met after many. But my question is, famous personalities when we see who had cognitive impairments, Alzheimer's dementia. Khushwant Singh died at the age of 99. He was obese. He did not have any dementia. I mean, he was very active. Another defense minister, because I belong to that same this thing. So George Fernandez, who was absolutely active, thin, slim. By 84 years he got, and within a year or two he deteriorated rapidly, died of Alzheimer's dementia. And that is just one observation, but not
actually,
very interesting to note.
Obesity is not the only cause.
Yeah, that must be.
We have around 70% association. There are other risk factors as well. So there are evidence that this can put at higher risk, but not that all the Alzheimer's are obese.
Absolutely. There is just this thing misnomer. And second is there are little bit controversy about statin. Mostly newer results shows that statin prevents Alzheimer's dementia. Initially, when statin came, a lot of concern. The statin early onset dementia probably started by the statin users. So little bit still a lot of debates are going on, and probably pro-statin and anti-statin groups, they are doing much of these things. And other adenosine is a new. This 2021 FDA cleared one monoclonal antibody, adenosine. That is also a new therapy in the Alzheimer's dementia, which targets the protein.
Yeah, we have therapies coming up, but the outcome is very unsatisfactory, and no treatment has proved its efficacy. Thank you for those comments. Thank you, sir.
Thank you again. Thank you very much, sir. So our next speaker is Dr. Saurabh Srivastava. He will be speaking on using PPI. How long is not too long? Dr. Saurabh Srivastava is a Professor of Medicine, Chief Medical Superintendent, Government Institute of Medical Science, Greater Noida. He has been honored and so many achievements in his career. He is having special interest in diabetes, endocrinology, and critical care. He has been awarded with GB Jain Orations IMACON 2014, awarded with the Padmakar, Tripathi Awards, UPDCon in 2015. He is Joint Secretary of the Uttar Pradesh Diabetic Associations. He is a Joint Secretary of RSDI UP Chapter Association of Editor, International Journal of Diabetes in Developing Countries. He is a member of ITIL Boards, Journal of Internal Medicine in India. He is having a lot of publications in reputed journals. Now I hand over the proceeding to Dr. Saurabh Srivastava. Please go ahead.
Thank you, Chairperson, for the kind introduction. First of all, I thank the organizers, especially Dr. Anil Maheshwari sir, Dr. Narasimha sir, Dr. Srinivas, Dr. Anubha for calling me and giving me opportunity to present in the present of August gathering. My topic is using PPI, how long is not too long. Why we are having this topic? We are having this topic because PPI is now very rampantly used. And it has been seen that there is a doubling of use of PPI in US from 1999 to 2012, and the expenditure is around $11 million annually. In India also, the use of PPI range between 30 to 90% in various studies. There is also the over-the-counter formulations of PPI which has been available. For the short-term use of heartburn, we usually go to the counter, over-the-counter, and take the medications. The unnecessary off-label long-term use of PPI is prevalent, and up to 65% of patients receive PPI therapy having no documented indication. And in the recent years, there have been studies which have shown association of variety of serious adverse effects from the use of long-term PPI. All these are observational studies. There are no conclusive evidence, but they are observational studies which have shown that there are serious adverse effects can occur with the long-term PPI use. So what are the common indications of PPI use? They are gastric ulcer, duodenal ulcer, and reflux esophagitis, where this is commonly used. They are also used to suppress the recurrence of gastric and duodenal ulcer with the low-dose aspirin or use of NSAIDs. They are also used in the eradication therapy of H. pylori. They are used in non-erosive gastroesophageal reflux disease, functional dyspepsia, and all these cases, the treatment goal is to relieve the symptom. These are the FDA approved indication and duration of therapy for the use of PPI, and you can very well see that acute gastritis and duodenal ulcer, the usual therapy is around 4 to 8 weeks. For the maintenance of healed duodenal ulcer, it is not known. For symptomatic GRD, again, it is 4 to 8 weeks. For erosive esophagitis, again 4 to 8 weeks. In Zollinger syndrome, it has to be taken for several years. If you are giving it for NSAID-induced gastric ulcer prophylaxis, then the duration is till you are giving NSAIDs. For NSAID-induced gastric ulcer, it is 4 to 8 weeks, and eradication of H. pylori, it is the standard triple drug therapy for 7 to 14 days. And then the meta-analysis, there is no indicator beyond the use of the standard therapy. So what are the long-term and short-term uses? For short-term user, it is used for GARD, gastric and duodenal ulcer, and H. pylori co-therapy. However, as a long-term therapy, it can be used for refractory GARD, erosive esophagitis, Barrett's esophagus, history of NSAID-induced bleeding ulcers, chronic anticoagulation after GI bleed, or used with the NSAID as dual antiplatelet agents. So, the indications of long-term PPI use can be classified as chronic medical conditions such as Zollinger syndrome causing pathological gastric hypersecretion, Barrett's esophagus, esophageal stenosis, structure, recent erosive ulcerative esophagitis, or used with a concurrent medication such as NSAIDs, high-dose corticosteroid, bisphosphonate, antiplatelet, anticoagulants, low-dose aspirin, and along with the pancreatic enzymes and cancer therapies. So these are the indications where it is used along with the other medications. And the continuous long-term PPI therapy is selective users. It can be used in GRD with troublesome symptoms, severe esophagitis, H. pylori eradication, prophylaxis of the patient on long-term NSAIDs and patients of Zollinger syndrome. So these are the common indications for the use of long-term NSAIDs. The duration I have already discussed, it is mostly 4 to 8 weeks, and in cases of NSAID induced, it is till the patient is taking NSAIDs. So what are the common adverse effects of PPIs? Why we are discussing this? Why we are more concerned about the long-term use? It has been seen in various observational studies that it has been associated with, it can affect myriad of all the organ systems are involved. The common are vitamin B12 deficiency, hypomagnesemia, osteoporosis, Clostridium difficile colitis, secretary dementia. And if you review the physiology, we see that to gastric, the acid secretion is by vagus nerve stimulation, gastrin and histamine, which are over here, and proton pump is here. Here the acid is released, and PPI blocks this, so the total of the acid is blocked. So these are the myriad of adverse effects which are associated with the chronic long-term PPI use. In CNS, it can cause headache, dementia, hepatic encephalopathy, cardiovascular stroke, myocardial infarction. In GI, nausea, vomiting, infections, Clostridium difficile infection, non-tarsified salmonella, spontaneous bacterial peritonitis. In blood, B12 deficiency, iron deficiency, hypomagnesemia, calcium deficiency. Musculoskeletal can increase the risk of fracture, osteoporosis and myopathy. In liver, it can increase the risk of hepatocellular carcinoma. In kidneys, it can cause acute intestinal nephritis, acute kidney injury, CKD. In respiratory, nosocomial. So, how these things are related? Peptic ulcer is given for these indications. If you use it for short term, it gives relief of symptom. But if you use for long term, it causes hypergastrinemia, leading to gastric atrophy, and which is the main culprit. If we see some of the important indications, gastric acid suppression causes hypergastrinemia, which causes rebound hyperacidity after discontinuing of the PPI therapy, and patient may again experience the symptoms suggestive of GERD. And this hypergastrinemia causes parietal cell hypertrophy as well as enterocorpus-like cell hyperplasia, which can lead to gastric cancer. This relationship is mostly observed in vitro. However, the case control study, one case control study has been published, which shows that it has been, there is a risk of for ECL neuroendocrine carcinoma with the use of PPI of more than 15 years. Risk of community acquired pneumonia, again, acid suppression lead to increase in the gastric pH, overgrowth of non-Helicobacter pylori bacteria in gastric juices, gastric mucosa and duodenum, impaired immune defense mechanism leading to microaspiration and lung colonization. Again, this is the current evidence shows that this is not conclusive. Coming to Clostridium difficile incidence, again, gastric acid is an important defense mechanism in colonization of stomach and intestinal tract. Several studies have indicated that it increases the risk of Clostridium difficile infection, and it is again attributed to the higher gastric pH. So it should be used with caution in patient having the risk for Clostridium difficile, such as immunocompromised elderly hospitalized patient and those taking broad spectrum antibiotics. Hypomagnesemia, it is a rare complications which can be manifested by muscle weakness, tetany, convulsions, arrhythmias, and hypertension. It can lead to secondary hypocalcemia and hypokalemia. There is a 40% increased risk of PPI, of hypomagnesemia in PPI users. However, on discontinuation, the magnesium level are normalized, but the hypomagnesemia again occurred once the PPI is restarted. And in most of the cases, the duration of therapy is more than 5 years. Fractures, again, fractures are associated with the epidemiological studies have shown that there is increased fracture risk. However, the causal relationship is being noted between the acid suppression and the calcium, reduced calcium absorption. And it has been seen that around 41% of reduced calcium absorption with 14 days of omeprazole therapy. So this can be the possible mechanism that PPI lead to hypomagnesemia, which can lead to decreased PTH, decreased crystals, increased oxidative stress leading to decreased osteoblastic reaction and increased osteoclastic reaction, ultimately leading to osteoporosis and fracture risk. And again, the long-term PPI therapy can lead to decreased B12 absorption, hypergastrenemia and calcium absorption, and all these lead to decreased bone strength, which can lead to fractures. B12 deficiency again is because of the acid suppression leading to atrophic gastritis, promoting bacterial overgrowth, which ingests cyanocobalamin and thus lead to deficiency of cyanocobalamin causing B12 deficiency. Acute intestinal nephritis is not related to the acid suppression effect of PPI. However, there is a humoral and cell-mediated hypersensitivity reaction which can lead to acute intestinal nephritis, which is spontaneously recover after the drug is stopped. The symptoms of AIN are common, which are always there. The PPI lead to hypomagnesemia, or there is a deposition because of immune response, which ultimately lead to acute intestinal nephritis, which can finally lead to CKD or end-stage renal disease. Again, this is the subacute cutaneous lupus erythematosus. This can also occur with the use of PPI. And again, there is a resolution period of after the drug discontinuation. This again, it has been shown that the PPI use can lead to increased atherosclerosis, myocardial infarction, and stroke. And here, the important thing is that the endothelial cells, there is a decrease in the effect on the endothelial cells leading to prothrombotic, impaired vasodilation, and decreased repair and regeneration, which lead to atherosclerotic changes and which can ultimately lead to myocardial infarction. In cases of patients with cirrhosis or chronic liver disease, again, if you are using PPI, they can lead to increased risk of spontaneous bacterial peritonitis, hepatic encephalopathy, infection, and mortality. So these are the acid inhibition unrelated adverse event, and these are the acid inhibition related adverse event which are related to use of PPI. So we have to balance both the things, that it has a therapeutic effect for the GRD, aspirin and NSAID ulcer and other indications. However, there are n number of adverse effects which are related. They are in observational studies which can be there. So one has to look for whether, how to use, how long to use, and where to use. These are the long-term effect of all these things. We have discussed all these things. And this is mainly because of the improper proton pump inhibitor use. There is over-prescription, not confirming diagnosis, wrong indication, continuing treatment despite negative pH studies, side effects are reported with little evidence, not knowing who will benefit from long-term PPI, not taking alternative therapies, improper technique of tapering PPI, and improper monitoring of over-monitoring. So all these things can lead to increased use of PPI. However, the causal relationship exists with only three things: that are enteric infections, structural and functional changes, acute kidney injury. However, other things, they have either low evidence of causality or insufficient evidence of causality. These are the studies which have seen all the effects which we are discussing, and you can very well see that the proper association either was not evaluated or they're not there. These are the studies. However, the American Gastroenterology Association, they have approved the following conditions for long-term use of daily PPI. They can be maintenance of symptoms and control of GERD, maintenance of healing erosive esophagitis, Barrett's esophagus, NSAID users, antiplatelet agent use, and pathological hypersecretory state such as Zollinger syndrome. And these three indications, GERD, esophagitis, NSAID use, and Zollinger syndrome are also approved by FDA. So what is long-term PPI use? Only 4 to 8 weeks of treatment with PPI can cause rebound hypersecretion. There is a trend in PPI use have been immensely investigated in the recent year. However, there is no consensus on how to define the long-term PPI use. There are substantial discrepancies in definition of long-term use, make it difficult to draw firm conclusion. And the studies which were there, they have taken various aspects of long-term PPI use. They have used it for adverse effects. They have used it for the treatment effects. They have used it for pharmacological epidemiological studies and discontinuation or dosage reduction. So these are the various studies which were seen, and in all these studies, the threshold for defining long-term PPI use varied from more than 2 weeks to more than 7 years of PPI use. The most common definition was more than 1 year or more than 6 months. Some studies also defined long-term use as more than 8 weeks. So we can divide the long-term use into 3 criteria. One is clinical criteria for long-term use. Second can be the research criteria for long-term use. And third can be the adverse effect causing long-term use. So for clinical criteria for long-term use, it can be assessed just after the initial course of PPI is finished. Whatever the indicated therapy is, that is usually 4 to 8 weeks. So continued treatment of PPI treatment after 2 or 4 to 8 weeks, depending on what was the indication of starting, whether it was dyspepsia, peptic ulcer, or reflux, you can consider these as long-term users. At this point of time, some patient might require long-term spontaneous PPI. Therefore, discussing appropriate therapy to the patient after 2 to 4 weeks, if the indication is uninvestigated dyspepsia and 4 to 8 weeks after the indication is reflux symptom, then this can be considered as long-term. For research criteria, one definition doesn't fit all. Long therapy may depend on the aim of study, for what aim the study was planned. It can be defined differently for side effect occurring after the years of continuous therapy or pharmacological studies such as drug utilization or doctor prescribing. It is not possible to have one definition for all long-term use for research purposes. So if the aim of the study is drug utilization or magnitude of long-term use, the long-term definition can be 6 months, which can be the possible definition. If we take adverse effect criteria, then if the aim of the study is side effect related to the long-term use, then the definition of the long-term use might need to be shorter or longer than 6 months, depending on the length of exposure time needed for side effect to occur. So whatever time the side effect occur, it can be taken as long-term. So prescriber should reevaluate the therapy, gradually reduce the dose of PPI over 30 days, and use other methods for the control of symptoms. So these are some taper plans for step-down therapy. The current medication, that is 4 to 8 weeks doses. Then you can taper it over 5 weeks. It is said that you can taper it over 5 weeks with the use of H2 blockers if you are trying to give it for long term. In first week, skip on Sunday. In second week, skip on Sunday and Saturday. In third week, skip on Thursday. Then in fourth week, Monday, Thursday and Saturday, and in the last week, you can replace it with H2 blocker if it is taken as a single use. If you are using twice a day, then the same plan, first stop the night drug, night dose, and then stop the, the morning dose. So it will take around 10 weeks to taper off, so that the hypergastrimia doesn't occur and reflex or rebound hypersecretion does not occur. This is again the same thing which we are discussing. Again, one important thing, the poor metabolizers can have the omeprazole, pantoprazole, lansoprazole and dexlansoprazole are not metabolized if the patient is poor metabolizer or having CYP2C19 genetic variant. And in these cases, you give short-term PPI. These drugs, omeprazole, pantoprazole, lansoprazole, and dexlansoprazole, they are used for short-term, and where there is no effect of this genetic variant, use these for long-term, such as rabeprazole or esomeprazole. These are not affected by this enzyme. So, to conclude, the long-term use could be defined as more than 4 to 8 weeks for the PPI use in the clinical context. One definition does not fit for all. For research purposes, more than 6 months of PPI use as a single possible definition for the long-term use in pharmacoepidemiological studies, and for the studies for adverse effect, the definition should be tailored to the exposure time needed for the side effect in question to occur, and the patient with GRD and acid-related complications such as erosive esophagitis, peptic ulcer stricture can take PPI for short-term healing, maintenance of healing, and long-term symptom control. Patients with uncomplicated GRD who respond to short-term PPI should subsequently attempt to stop or reduce them. Patients with Barrett's esophagus and symptomatic GRD can take long-term PPI. Patients at high risk of ulcer-related bleeding from NSAID should take a PPI if they continue to take NSAID. The dose of long-term PPI should be periodically re-evaluated so that the lowest effective PPI dose can be prescribed to manage the condition, and long-term PPI user should not routinely raise their intake of calcium, B12 or magnesium beyond the recommended daily allowance. Thank you.
So, after NSAID, PPIs are the most commonly abused drugs or misused drugs actually. So most of our prescriptions are they containing any kinds of PPI, and among that just Dr. Saurabh Srivastava has covered this topic entirely very well. He has depicted that almost all systems of the bodies can be affected if you overuse or prolong use without indications, very clear message. So Dr. Saurabh, one question for you. So according to you, just which is the best PPI or H2 blockers in your opinion? So we recommend for the long durations because certain conditions patients require long-term PPIs or acid suppressions.
Sir, what I feel that if you see the literature, it is said that you just first control the symptoms, and once the symptoms are controlled, try to block, take care of only H2 blocker, or you can take intermittent PPI. It is not that you just start off with the medication, you have to take daily PPI. If the symptoms are not there, you can stop the medication, and once the symptoms are there, you can take intermittent PPI. So in discontinuation phase or step down phase, it is recommended that you shift to H2 blocker, and if H2 blocker, it is not controlled to H2 blocker, you can take intermittent doses of PPI. And again, as I already said, that the long-term metabolizers, the rabeprazole and esomeprazole can be taken up safely for the long-term use, and other drugs, if there's some genetic variation, it can cause more adverse effect as compared to other drugs.
Almost few months back, there was a reports as this H2 receptor blockers, they can cause malignancy, but patients are still taking this ranitidine, their drugs for the long use. So what is your take on this ranitidine, just the H2 blockers?
Yes, sir. So the only thing is that no drug should be continued for lifelong. It is better to stop and start therapy. Whenever it is required, just take this therapy, and whenever it is not there, you should stop it. Any drug taken for long term can cause some or the other adverse event.
Any comments over this gastric dysbiosis? Yes. Question, please.
Therapy, you have recommended ranitidine, excellent sir, but now because of this NMDA content of ranitidine in question, sir, can we go for famotidine, which is much cheaper, 40 paisa or 30 paisa per tablet, and doesn't have that problem? So,
Sir, we can use. We have to switch over. We have to just, sir, as I show the pathophysiology, that PPI is blocking whole of the PPI. Acid is not released. So the adverse effect is because of hypergastrenemia and all that, which are the other potential sources for release of acid. They are increased in the circulation because PPI acid is not released. So if you are using some other drugs which are antihistaminic blocker, famotidine can be very well taken care of, what I feel.
Sir, the biggest problem is psychosomatic dependence of patient. He or she is, when sees ki the medicine of 12 rupees has been reduced to 1.5 rupees or 50 paisa famotidine, then I believe majority of them are psychosomatically dependent upon PPIs. This is my
You are right,
observation.
very right, sir. Any other question, please? So now we close this session. We move to the next session. Thank you very much. Thank you, Dr. Narasimhan.
Thank you, sir.
So after this very stimulating talk on proton pump blockers, we have the next session, and for this I will request Dr. Raghunanda Rao Digamurthy and Dr. Ashish Srivastav to kindly chair the session. And we had two speakers in this, so we will be having Dr. Sanjay Shah and Dr. Bharat has not come, and Dr. Mohsin Aslam. So two people will be speaking in this session, Dr. Sanjay Shah and Dr. Mohsin Aslam.
Good morning, ladies and gentlemen. Let me introduce Dr. Sanjay Shah, who is going to talk to us on old is gold, still stands in medicine. He is the medical director of Swami Ram Prakash Charitable Hospital in Haridwar, run by the Swami Vivekananda Health Mission Society of Uttarakhand. He was the vice president of the Association of Physicians of India of Uttarakhand, and is the chairman of the Uttarakhand division of the RSSDI. So he will talk to us on old is gold, still stands in medicine.
A warm good morning, everyone. And chairpersons, thank you for the kind words. And I bring greetings from the holy city of Haridwar in Uttarakhand, where I've been there for last 3 decades. And excellent 2 days deliberations, a very good academic program, all thanks to the hard work done by Dr. Anuj, Dr. Narsingh, Dr. Srinivas Murthy, Dr. Anubhava, excellent program. And mine is more of a general topic. We've had discussions on nearly every aspect of disease. So when we look back what we have discussed in the last 2 days, yesterday's oration by Dr. Nageshwar Reddy also delved on gut microbiota. So there is where I was discussing with him that we need to do a lot more studies on it. And this is the area where a lot of new things are coming up. This is a commensal in the intestine for, say, centuries, and has helped protect generations and generations of humans over the last so many years. It is not moving. So when we discuss old is gold, I will be more particular that it is more of what we have learned from the ancient times rather than just old. So medicine over the last centuries, maybe hundreds and thousands of centuries, have developed, and healthcare, we have had various schools of medicine. And in the prehistoric times, when men believed that illness and diseases were a punishment from the gods, and the first physicians were witch doctors who treated illness with ceremonies. And then later on we had more of evidence in the management in various later on times, and different tribes, they commingled, and exchange of tribal folklore, ever increasing compendium of useful, not so useful, even dangerous remedies developed over the years. Then we had the Egyptian medicine, a very old civilization, where they had their own beliefs and different gods and demons and spirits, and they attributed the diseases to these. And ancient Egypt, more than 3 to 500 years BC, was the dawn of the medical care, which was greatly influenced by wealth and trade. You also know that Chinese medicine today is a vast subject, and there were various dynasties and who were there developing these ancient Chinese herbs and medications. Also the Greek medicine, they knew various compounds like belladonna, peppermint, aniseed, but also believed in the supernatural ideas. So while ancient civilizations were undoubtedly versed in the use of herbs as medicines, extensive written records appeared only during the time of the Greeks. They documented their findings, and we do have it today. Then the most popular science and the, I would say not just science, it's a way of life, Ayurveda. So Dr. Narsingh himself is, I may say, the pioneer of chrono medicine. So he is really well versed into how a human cycle and our biological rhythm affects our health. So here we have the traditional Hindu medical system, which was native to this subcontinent, and it consisted of diet, herbal treatments, and yoga. Also meditation, also various other practices like hypnosis, which we study very little about. And these are ancient, which have been passed down the centuries. We had Dhanvantri as the physician of the gods, who emerged from the ocean of milk with Amrit and herbs in the hands, the nectar of life. And then there are the various literatures that we have, the Samhitas, the Chakras, the Sushitras, the Agniveshas, and the ancient medical texts, which unfortunately quite a few were destroyed when we had the great universities of ancient times, Nalinda and Takshila, which were destroyed, and we lost quite a bit. But then if we delve into it, we will see that there was a huge mass of knowledge that was, handed down from generation to generation. See, the oldest surviving complete medical system in the world. It highlights the way of life and teaches how to maintain and protect health. We have been discussing over medications and what not to be used. So here we had a science and a way of living that imparted complete wellness to the human race. Even in our own clinical practice, we do compare, whenever we treat our chronic illness patients, we compare the human race to the animals in the wild. And we ask our patients, those animals are not on any medication. They were living on the same planet. Some of them are within half a kilometer of where you are residing, I tell them. And your lifestyle and their lifestyle have remained the same for centuries. And our lifestyle, I think, has had a drastic difference during our own lifetime. We've seen our grandparents live to 80 years and 100 years, and we are seeing now children, young children coming with heart disease, metabolic disorders, everything. So this we know that how it evolved, the ancient practice of medicine and surgery. There have been various subjects which have been taught over the years, and Sushruta have been recognized by various modalities of science all over the world. So, need not go too much in this. He was a surgeon par excellence, had written so much about various aspects of surgery, And the Sushruta Samhita contains 184 chapters and describes 1220 illnesses, 700 medicinal plants, has a detailed study of anatomy, 64 preparations from the mineral sources, and 57 preparations based in the animal sources. Charak again was another, we all know, one of the principal contributions to the ancient art and science of Ayurveda. So a lot of divisions, everything in detail giving. This is just not in science, even astronomy if you go into, there have been so much written during the ancient times. And what we say that it is the oldest, we do not know how old it is. The initial was just handed over by word of mouth. Then when we come to we call it allopathy, we prefer calling it the rational system of medicine. So when we talk about the medicine in the 17th and the 18th century, we've had various scientists who did a lot of study on the cell, like Robert Hooke, the microscope, surgery was discovered, pathology, obs and gynae, scurvy, and anesthesia by the various scientists who have been there in the 17th and the 18th century. And the structure of the human body was almost fully known due to the new methods of microscopy and injections. Even the body's microscopic structure was well understood. Then there were various practices, like the vaccine was discovered when Edward Jenner, who was a pupil of John Hunter, invented the world's first vaccine for smallpox in 1789. Jenner inoculating James Phillips with cowpox, a virus similar to smallpox, to create immunity to smallpox. This was a scratch that saved 1 million lives, and it led to the discovery of vaccines. Then when we come to the 20th century, we have surgical and diagnostic techniques which were developed to cure once fatal conditions. The organ transplantation was started in 1954, and limbs started getting reattached. We had test tube babies in 1978. Amniocentesis was being done, and artificial hearts and cardiac transplantation and lung transplantation and renal transplantations were being done. So further progress in medicine, social sciences, technology and economy led to increased life expectancy in wealthy populations and change in the morbidity and mortality patterns. Then when we come to the 21st century, first draft of the human genome is announced in 2000, and the finalized version is released 3 years later. In 2006, we have the mini liver. 2007, we have the scientists discover how to use human skin cells to create a embryonic stem cell. And 2014, FDA approves the first human clinical trials in the United States for a wearable artificial kidney. Then we have the future trends in medicine. We have nanomedicine, and this again has its roots way back to the past, and we used to have food being served in silver and copper utensils, and the nanoparticles used to get absorbed. So the beneficial effects have been seen centuries back. Further research in stem cells, and then came the era of personalized medicine. So it is now more of a patient-centric approach rather than a pharmacological-centric approach. This is what we have learned over the years, how to treat and manage different conditions. Day by day, the technology is developing and old is getting replaced by the new. But can we simply forget the old methods that are still reliable and easy? Dr. Muruganathan spoke on empathy yesterday. So, again, I must congratulate the organizers that we had such a wild array of topics being discussed. So, empathy as a subject, he described so well in his talk, and that is what everybody should have. He also was telling us about the MRCP examinations, how the incidents, when you take a history, how you must go about it. So the newer generations have to be taught what is right. And traditional medicine, as we all know, definitely is in the revival stage. We must imbibe the good from wherever possible we can get. And for thousands and thousands of years, people around the world have healed the sick with herbal and animal-derived medicines, quite of which have been now, purified and incorporated into modern medicines. This has happened especially in Africa and Asia, where there was a lot of tribal and ancient medicine practices. The world is desperately seeking new drugs. We need to, the truth is that modern medicine is short of treatments in a lot of areas. Say, like, if we come to the major organs, renal failure for one. We have a lot of new drugs coming up, a lot of trials being done. But I, for one, warn my diabetic patients, please don't let your kidneys fail. The earliest sign of renal failure, and there your downhill course will start. So preserve your kidneys. And how do we preserve them? Do we have any medicines which can reverse renal failure? Hardly. Very few of them. And that too when we start them in the initial phases. And it also takes years for a new drug to get through the research and development pipeline, and also a lot of expenses are involved. Apart from this, growing drug resistance is partly caused by misuse of medicine, which was being discussed in the previous session, that do we need to over-prescribe medications? So when we are talking about PPIs and NSAIDs, I would add to it the antimicrobial stewardship, where we should prescribe antimicrobials where they are actually required. Also, we are in the era of evidence-based medicine. We all practice that. And there have been various milestones right from 900 AD to present times when evidence-based medicine was being practiced. So it is basically clinical judgment versus relevant scientific evidence and the patient's values and preferences all combined together. So it integrates best research evidence with clinical expertise and patient values. We've had various examples, Whistler-Mausler, bloodletting, and then we have various old therapies that are still being used very well today. Like leeches are being used, and penicillin, sulfur drugs, aspirin, nitroglycerin, first used in 1867. Insulin, we know, has completed 100 years, and is a life-saving medication. Same with morphine and digitalis. So with advancing medicine and also poor health, do we need to introspect ourselves? Thank you very much. This is, I don't know how many people will guess where this picture is taken from. This is the view of the Himalayas. No, view of the Himalayas, not from Kanchenjunga, but from a place where most of you must have visited, that is Haridwar. People born in Haridwar have not seen the Himalayas from Haridwar. But from my terrace or from my bedroom, I can have this view on a clear day. So ancient old Himalayas, visible from a place where you don't expect to see them. This is where we are working. This is one of the hospitals of the Swami Vivekanand Health Mission Society. This is the urban hospital. Rest 10 hospitals in Uttarakhand are in the rural areas, and 3 high altitude hospitals in Kedarnath Dham, Badrinath Dham and Gangotri. All those 3 hospitals have had a huge patient number this year. We had more than 130,000 patients in Kedarnath alone, 8 bed hospitals, and no billing counters. The rest of the hospitals are all charitable, and we are covering around 500 villages, and we aim to do some data collection and start publishing our papers in the near future. We celebrated the International Yoga Day in our hospital, as we do in all our hospitals. And in UP for Dr. Anuj and Dr. Narsingh and Dr. Anuba, we have a 400-bedded hospital coming up in Vrindavan, and another in Ayodhya, Prayagraj, and Kashi to follow. I don't know when we'll come to Awadh, Lucknow, but the rest of the places are there. Ancient hills with the golden. This was the photograph we took in Badrinath last year. So, gold is definitely gold. Thank you very much.
Thank you very much, sir, for that exposition. That we should not lose older values and insight, and we need to rededicate ourselves to what is typically called as ethnopharmacology. I also partly edit the International Journal of Ethnopharmacology, and I see extraordinary synthesis and merging of what they call as folk medicine with modern medicine, which I don't know as Indian allopaths we are doing at all any justice to our own Ayurvedic system. If you see the Chinese university in the medical college itself, they train their doctors in modern medicine along with the Chinese medicine. And 99.9% of the patients have expressed extraordinarily good views about Chinese medicine. Whether it helps them or not, it certainly doesn't seem to harm them at all. We always blame herbs for liver injury, renal injury, and injury to every other organ in the body, especially the heavy metals. But I don't know whether that is the intention of the modern medicine, to blame what probably they cannot help in any way. Any views on that?
Yeah, definitely. I definitely agree that we must incorporate whatever good there is. That is, and this has to be done right from the curriculum level. Yeah. You don't have to start practicing and then say that we need to go into it. So the exposure, the government is also doing it now. And the best part is that we have also tied up with S. Vyasa University. The chancellor is Dr. Nagendra. He was a NASA scientist in charge of the lunar mission. And yes, anybody from Bengaluru would know that he has a huge university campus there, S. Vyasa. Also has branches in a few other countries, and they're doing a lot of research based. So we have tied up with them. We have a Yoga and Panchkarm Center, which is in collaboration with the S. Vyasa University. And the second thing, anybody who's coming to Uttarakhand, anywhere, you will find one of our hospitals, including at the Dhams, en route to the Dhams, and at Haridwar and near Dehradun. So you are most welcome to visit. And we are also, now what I have done, since I am the chairman of the RSSDI, AIMS is next to us, Himalayan Institute is very close by. We have a main Indres hospital and a Subharti and a government hospital. Another medical college is coming up in Haridwar. So all these we are tying up and doing research. So we have submitted a lot of research abstracts to the RSSDI, and hopefully within the next 6 months there would be some publication from Uttarakhand also.
Sir, one of the very positive comment about the old is gold. One of the theory why Indian rural people and semi-rural people, semi-urban people in India and third world countries, they have lesser propensity for the autoimmune disorders. The reason has been given that the newborn was being kept with the mothers for the first few days, and they were not bathed. Usko sorry bolte the Hindi mein, and the good bacteria, good microbes, they were used to be given to the newborn, new babies. And this is one of those theories. And then again, this fasting theory, it is now a well-known fact. So old is gold.
So today happens to be Ekadasi. So
yes, sir.
I was sitting having fruits when I was having breakfast, and Dr. Muruganathan was asking, why aren't you eating? I said, this is my breakfast. Today is Ekadasi. And if you go back to 2016, autophagy, the Nobel Prize in Physiology and Medicine, was basically intermittent fasting and fasting as such.
Thank you, sir. Thank you very much.
Thank you.
With that, we pass on to the next speaker. I would like my co-chair to introduce Dr. Mohsin Aslam.
He is consultant physician at the Asian Institute of Gastroenterology, Hyderabad. And there is long list of achievements, and there is long list of awards. He has got more than 25 presentations and lectures at the local CMEs, and his area of interest is pancreatic diabetes mellitus, that is T3, and the metabolic dysfunctions associated fatty liver disease. Welcome, sir.
Thank you, sir, and good morning, everybody. First of all, I would like to thank Dr. Anuj Maheshwari, sir, Dr. Narsim Verma, sir, Srinivas Murthy, sir, for giving me this opportunity. So I'll be talking on malabsorption syndrome in India and overview. This condition is very common in our clinical practice. We need not present with, patient might not present with frank malnutrition symptoms, but they have associated GI symptoms, which is very common in our GI practice, and we ignore. And in the previous talks, we said we usually treat them with PPIs and prokinetic agents. And earlier, in the last 2 decades, before 2 decades, the infectious causes were very common for malabsorption syndrome, but due to improvement in sanitation and standard of living, the infectious diseases are coming down, and the other causes like autoimmune conditions like celiac disease, inflammatory bowel disease are increasing, which is responsible for malabsorption syndrome in India. So, historical perspective, the ancient book Charaka Samhita, which is a Sanskrit book on Ayurvedic medicine, also mentions about malabsorption syndrome, and the term sprue was first introduced by Manson in 1880s. These epidemics of malabsorption were also noted in India during the times of World War II, and it is reported in South India from 1960s to early 1980s. The GI system is responsible for the motility, secretion, regulation and digestion of nutrients consumed in the diet. The GI tract is involved in the absorption of fats, carbohydrates, proteins, vitamins, minerals, and trace elements. So any disruption in the absorption of these nutrients will result in the GI symptoms, and if continued for long, results in malabsorption. So for the normal nutrient absorption requires 3 steps. First is luminal and breast border processing, where the digestive enzymes break down the complex molecules into the simple molecules for that to be absorbed. And then the absorption across the cells into intestinal mucosa and transport into the circulation and lymphatics. So what is malabsorption and maldigestion? Malabsorption is impaired absorption of nutrients caused by any disruption in the process of absorption of the normal absorption. Whereas impaired digestion of the nutrients within the intestinal lumen because of various deficiencies of enzymes or at the brush border membrane which interferes with the absorption of the nutrients is maldigestion. However, in the clinical practice, malabsorption refers to the deficiencies in both the process of digestion and absorption. Malabsorption and maldigestion might differ pathophysiologically, but these two processes are interdependent. So examples of malabsorption and maldigestion. Rather than, we can say conditions causing malabsorption and maldigestion. So malabsorption seen in Crohn's disease, celiac disease, lactose intolerance, small intestinal resection or bacterial overgrowth, Whipple's disease, radiation enteritis and pernicious anemia. And maldigestion as because of enzyme deficiencies resulting in malabsorption. These are pancreatic insufficiencies, particularly fat malabsorption, gastric resection, bile acid deficiencies may be secondary to hepatobiliary obstruction and cirrhosis of liver. So malabsorption develops when the components of the mucosa. So when the components of mucosa are disturbed or damaged by a variety of reasons like immunological causes or infections or toxic or chemical substances. Then malabsorption can affect both macronutrient or micronutrient absorption or both, causing excessive fecal excretion, nutritional deficiencies and GI symptoms. Malabsorption syndrome may be global, that is affecting the absorption of and all the components of the diet, or may be isolated to specific nutrients. Causes, again, infectious causes being more common in India, particularly tropical sprue, followed by autoimmune conditions like gluten-sensitive enteropathy, commonly known as celiac disease, inherited or metabolic disorders, immune disorders, hypersensitivity, particularly eosinophilic gastroenteritis, with the frequencies increasing, neoplastic conditions, systemic diseases, and inflammatory bowel diseases like Crohn's disease and ulcerative colitis. The incidence of these two conditions is also increasing, maybe because of the change in our dietary pattern and lifestyle. So again, classification of malabsorption, again based on where the defect is, either due to the defective intraluminal digestion, as seen in the enzyme deficiencies, malabsorption due to mucosal or mural abnormalities, as seen in celiac disease and other diseases affecting the intestinal mucosa, and due to infections. Mechanism of malabsorption in the luminal phase because of the enzyme deficiencies like enterokinases, deconjugation of bile acids, then luminal bacterial overgrowth or luminal dysmotility resulting in a maldigestion and ultimately malabsorption. In the mucosal phase, because of the disruption of the mucosal integrity or impaired hydrolysis activity at the mucosal brush border, resulting in the decreased absorption of the nutrients. In the transport phase, any obstruction to the lymphatics or circulation resulting in malabsorption. So mucosal pathology, this is a normal mucosa. We might see increase in the intraepithelial lymphocytosis, but the most common finding is mild to moderate villus blunting and crypt hyperplasia without any significant diagnostic findings. This flat mucosa is seen in advanced diseases or inflammatory conditions like Crohn's disease. So clinical features, they may present with diarrhea, steatorrhea, malnutrition, weight loss, abdominal pain and anemia. Although all three major nutrients may be malabsorbed, but the clinical symptoms are majorly due to the malabsorption of fat and carbohydrates. So consequences, iron deficiency anemia due to may be there, macrocytic anemia because of B12 or folic acid deficiency, again bleeding, bruising and petechiae because of vitamin K and C deficiencies, carpopedal spasm, calcium deficiencies, edema, protein and albumin deficiency, glossitis, B complex deficiency, night blindness, vitamin A malabsorption, pain in limbs, bones, pathological factors, again calcium deficiency, vitamin D and other electrolytes, peripheral neuropathy, again B12, B1 and B6 deficiencies. So now malabsorption syndrome in India. In the developing countries, non-infective causes are the predominant cause of malabsorption, whereas tropical sprue and infective causes were common in developing countries like India. However, in the last 2 decades, India has seen the emergence of celiac disease and inflammatory bowel disease. This may be due to socioeconomic development and improvement in health and sanitation during this period, which has reduced the incidence of chronic infective diarrhea and tropical sprue and changed the spectrum of malabsorption. So, chronic small bowel diarrhea with malabsorption poses a significant impairment of health-related quality of life in India, and India is apparently witnessing a paradigm shift from the infectious causes to non-infectious causes. As a result, maybe as the sanitation and hygienic conditions are improving. So there is evidence from large number of studies across India which have shown that the incidence of celiac disease is increasing, but still the prevalence of tropical sprue is high. So this is one of the studies from South India, from the Warangal, involving 200 patients. Here you can see almost 41 the patients had a tropical sprue as a major cause of malabsorption, followed by celiac disease, and then other infective causes. These are the various studies. You can see studies across North India from which has shown celiac disease as a 65%, which is very high, followed by tropical sprue. Another study from South India CMC Vellore with 124 patients showing tropical sprue the most common cause, followed by celiac disease and Crohn's disease. And again from another study from Lucknow showing tropical sprue is a commonest etiology, and one study from Mumbai showing celiac disease again as a common cause. So these two are almost common causes. One study we can note that from the north and western population, celiac disease is more when compared to southern population. This may be because the northern population, they consume more of wheat-based diet, and in South India they consume more of rice-based diet. So coming to general evaluation for malabsorption syndromes, when the history and physical examinations are suspicion of malabsorption syndrome without any strong evidence supporting for diagnosis, then we can go for general evaluation to look for support the diagnosis but not diagnostic test. This include metabolic panel like liver function test, renal function test, electrolyte disturbances, hemogram to look for anemia, albumin levels, and other elements like zinc, magnesium, vitamins, to look for the support, look for supportive diagnosis for malabsorption. And fecal fat test, it is more sensitive for fat malabsorption syndromes. Fecal fat estimation from the single sample, but if you have a strong suspicion, then we can go for 72-hour fecal fat. It is a gold standard, but again it is a cumbersome to perform. Other tests include Sudan 3 stain, acid steatocrit. Another test is near infrared reflectance analysis, almost comparable to 72-hour fecal fat estimation, but advantage is it is faster and also measure nitrogen and carbohydrates while measuring the fecal fat. Specific investigations, when history and physical examination are confirming the diagnosis of malabsorption, then we need not perform general tests, directly we go for specific tests. For example, history of recurrent acute pancreatitis or alcohol use, we can directly go for imaging to look for pancreatitis as a cause. And patient presenting with abdominal discomfort, which is relieved on taking gluten-free diet, we can see that suspect it is a celiac disease and go for specific tests like TTG antibodies or endomycin antibodies and duodenal biopsies. Breath test to confirm carbohydrate malabsorption syndrome or small intestinal bacterial overgrowth. However, jejunal aspirate culture is a gold standard for small intestinal bacterial overgrowth. Other CT imaging, MRCP and ERCP to look for pancreatic pathology and also for ductal abnormalities. MR elastography to look for liver stiffness as in NASH and hepatic amyloidosis and other conditions causing liver abnormalities. Endoscopies and colonoscopy with biopsy to visualize the mucosa and also to take biopsy to confirm the diagnosis of diseases like Crohn's disease, ulcerative colitis, jejunalitis, and celiac disease. Acid fast staining, it helps in differentiating Trophorema whipple causing Whipple's disease versus Mycobacterium avium because these two have almost similar features on biopsy. So this slide summarizes the evaluation of malabsorption, which we have discussed earlier. I'll just skip this slide. So treatment is like correcting the deficiencies, treating the underlying cause, and avoiding triggering factors, particularly by diet modification, and treating symptoms like diarrhea, pain, abdomen. Treatment is usually conservative with dietary changes such as food avoidance and supplementations. However, invasive procedures, surgeries might be needed as in the Crohn's disease, where the strictures are formed like transections, resections, and transplants in cirrhosis of liver. Complications, again, if untreated and prolonged, then let's result in chronic complications like present with chronic diarrhea, bloating, malnutrition, weight loss, vitamin deficiencies resulting in osteomalacia, rickets, skin changes, hematological conditions like anemia and coagulopathy, visual impairment, then dermatological manifestations, musculoskeletal dysfunctions, electrolyte disturbances, cardiovascular disease like cardiac arrhythmias, neurological dysfunction resulting in peripheral neuropathy, and endocrine dysfunction like parathyroid dysfunction and chronic fatigue. So, as we have seen in the earlier slides that celiac disease and tropical sprue are the most common causes of malabsorption in India, I'd like to discuss something about diagnosis and management in brief. So, celiac disease is a multi-system autoimmune condition especially triggered by gluten ingestion in a genetically predisposed individual, and consumption of a very high gluten diet up to 20 grams per day has led to an increased prevalence and incidence of celiac disease. So diagnosis, gold standard is duodenal biopsy, serological test, and intestinal biopsies. Serological test includes anti-TTG antibodies, anti-endomycin antibodies, deaminated gliadin peptides, and HLA-DQ, DQ8 positivity. And the combination of anti-TTG, EMA, and HLA-DQ, DQ8 positivity, that is a triple criteria, had a good accuracy across the range of pre-test probabilities, and duodenal biopsy is a pillar for the diagnosis of the celiac disease. So management, again gluten-free diet, other drugs like larazotide, acetate, and gluten-specific proteases from the bacterial mix are in clinical trials and have shown efficacy in symptom control rather than restoring the intestinal barrier. Again, vaccines aimed at desensitizing patients with celiac disease to gliadin peptides are under clinical trials. Again, tropical sprue, it is a diagnosis of exclusion when the symptoms of malabsorption are present and we don't find any other cause. Yes, we can make a diagnosis of malabsorption syndrome. Again, diagnostic criteria, 3 tests, stool fat estimation, absorption of D-xylose for looking for carbohydrate malabsorption, and absorption of vitamin B12 by measuring B12 levels. Any 2 abnormal tests in the setting consistent with a tropical sprue in the absence of other causes of malabsorption. Then biopsies from the jejunal mucosa or duodenal mucosa will help in confirming the diagnosis. So biopsy will show villus atrophy, then crypt elongation and cell infiltration of the lamina propria. The villus to crypt ratio is reduced to 1.5:1 from 4:1, which is seen in normal mucosa. So management again includes symptomatic treatment, folate supplementation, and antibiotics like tetracycline 250 mg 4 times daily or doxycycline 100 mg once daily for 3 to 6 months therapy usually helps in symptom relief and improvement in the malabsorption symptoms. Restriction of long chain fatty acids in diet and substitution with medium chain triglycerides will help. So to summarize, malabsorption syndrome is a common condition in medical practice in tropics including India. There is a constant change in the order of etiologies causing malabsorption syndromes in India. So India has seen the emergence of celiac disease and Crohn's disease in the last 2 decades as a cause of malabsorption. The socioeconomic health development and improvement and sanitation might have reduced the chronic infective diarrhea incidence and tropical sprue and changed the malabsorption spectrum. Due to lack of awareness among physicians about celiac disease in tropical countries, it may remain undiagnosed for a long period and results in the complications. Thank you.
In case we are free of any questions or doubts, I would once again like to thank Dr. Aslam for his talk on malabsorption in India, especially with regard to celiac disease and tropical sprue. Thank you, sir. And we thank the organizers for giving us this opportunity. On behalf of my co-chair, I would like to thank you all for your patient hearing. To the organizers, please.
Thank you, chairpersons and speakers. For the next session, I would like to invite our next chairpersons, Dr. V.V. Jindal, MD, FICP, FAMS, FIAMS, FIACM, HOD, Department of Medicine, St. Joseph Hospital, Ghaziabad, Dr. Alok Modi, MD, FISH, FACP, PGDL, Consultant Physicians and Diabetologist at Jupiter Hospital, Kevalya Hospital, Dr. Modi Diabetes Center, Horizon Prime Hospital. He is awarded top 20 diabetologist award in Mumbai. Thank you, sir.
Very good morning. Thank you, Chairperson, ladies and gentlemen. First of all, I would like to thank the organizers, especially Anuj sir, Srivastava madam, Murthy sir, and Narasimha sir for giving me this opportunity. I know the topic title may be sounding new to you. You may have read this topic somewhere in your textbooks, but due to the limited resources available in our country, I think most of you may not have practiced what is HBOT or hyperbaric oxygen therapy and how we can utilize it in clinical medicine. We all know we are surviving at a sea level pressure with the 21% of oxygen in our body. We are doing wonders. Now we will see if we get 100% oxygen under an increased pressure, what we can do. So this is my disclaimer slide. I'll be mentioning about the principles and mechanism and the indications approved by the higher authority and the problem wounds, especially most of us are diabetes, practicing in the field of diabetes, our experience and available evidences. This is a history of HBOT because you all know that with the discovery of the oxygen in 1775 by Priestley has revolutionized the use of oxygen in clinical practice. We know that the Henshaw first used compressed air about 400 years back, but this has gained momentum over last 200 years, but still it is not that used in our country. So the first use which has been used in decompression sickness way back in 1937 from there up, because during the Second World War, and 1975 the regulation body has come into place, which is in place in USA. And in 1966 Indian Navy has first obtained the hyperbaric oxygen chamber, and they were using it for the battlefield injuries and decompression sickness, which was very common in divers. And the American College of Hyperbaric Medicine and International Society has revolutionized the use of HBOT in clinical medicine. The HBOT simply means the hyper means high, the baric means pressure. You are giving an intermittent inhalation of 100% oxygen for a patient who will be sitting in a specialized chamber. I think the 1 atmosphere what we are living, that is 760 millimeters of mercury. So based on the basic simple principle of what you call the Henry's law, when we go back to our +2 time, we know that Henry's law, because wherever we increase the pressure, the solubility of a gas will be increasing. So we all know that oxygen transport is basically 97% bound to hemoglobin, and rest is in the dissolved form. So the dissolved amount of oxygen which is in the plasma, which is the principal factor which decides the cellular function to happen. So wherever you increase the pressure, there will be more oxygen will be absorbed, and as depicted in the picture, you can see when you give under higher pressure 100% oxygen, there will be more oxygen which is diffused in the plasma, and the cellular function will happen. So this is the effect of HBOT. If you give from 1 atmosphere absolute where you and me is sitting now, it will go into 5.62 when we subject a person to 2 or 2.5 ATA in an increased pressure. We have two options to give, that is one is a monoplace chamber, one person at a time, but it has got its own limitations. Multiplace means you can keep more persons. We use a 4 person at a time, and we can, even the foreign countries has got 10 or 15 people at a time. This is the lower one is a HAPA bag, which is usually used in transporting a patient from a critical area, especially those who are going for a high altitude visit. If they come across a high altitude pulmonary edema and cerebral edema, they'll be immediately transported to a lower altitude level to avoid the consequences. Little bit of physiology, how it acts is, we can know that the high oxygen tension overcomes the hypoxia, and there will be centrifugal diffusion which will be promoted at the capillaries and the venous level, so more oxygen will be diffused. As you can see, whenever there is hyperoxia, there will be more oxygen which is diffused. There will be reduction in edema, but there won't be any compromise in cardiac output. There will be a 25%, but it will not produce any physiological problem. So this is very important in facilitating treating the crush injuries and compartment syndrome, and facilitating the take-up of flaps and skin graft surgeries. As you all know, oxygen has got a bactericidal and bacteriostatic role, because the first use of HBO has been come into picture when they started using it against the gas gangrene, which is very common among our soldiers when they are getting exposed to battlefield injuries. So it has got a potential anaerobic thing, and the PMN cells are rendered sluggish and ineffective in hypoxic environment. So if you can overcome the hypoxia, the chemotaxis and all other functions of the polymorphonuclear cells will improve. The angiogenesis and epithelialization, in wound healing, the basic thing is the basement membrane, which consists of the type 4 collagen, and hyperoxia enhances the endothelial response to angiogenic factors. One thing you have to keep it in mind in angiogenesis, the studies had proved that this angiogenesis will never promote a tumorogenesis. Cell replication, because we all know the terminal step of collagen synthesis, the hydroxylation of proline, lysine, it depends upon the oxygen tension. So if we can improve the oxygen tension, the local tissue above 30 millimeters of mercury, and the collagen synthesis will be promoted, and this will help in the wound healing. Antibiotic synergy, we use, these are the reserved antibiotics, especially you use in diabetic food management, that is aminoglycosides, the fluoroquinolones. These need the presence of oxygen for a transport across the membrane, and when you subject an individual to HBOT, the membrane transport of these molecules are found to be improved, because they are dependent upon the oxygen saturation. Regarding the selection of patients, after the detailed history and the clinical examination, you have to do all the routine clinical biochemical evaluation irrespective of the etiology, rule out the pregnancy. Chest X-ray is a must, but two investigations which is very important is you have to take an ECG and a pulmonary function test. ECG, if there is any evidence of bradyarrhythmia, you please don't subject the individual for HBOT, and pulmonary function test to rule out whether there is a severe obstructive or a restrictive lung disease is there. And if there is a history of COPD or chronic bronchitis, it's better to do an HRCT to rule out any possibility of emphysematous bullae, otherwise it can rupture under the high pressure. This is basically for the wound management that our center is concentrating. We take a pre and post wound photograph, we'll do the Doppler study and the TCPO2 measurement. MRI in selected cases when we want to rule out a Charcot arthropathy or an osteomyelitis. This is a profile, this is an internationally accepted profile. One session, which is of 90 minutes duration, and the frequency is 5 days a week. Why we are restricted to 5 days a week for 90 minutes is, if there is any possibility of a cumulative toxogen, accumulation with oxygen, it will be prevented, because there won't be any pulmonary toxicity or CNS toxicity if you follow this schedule. Because whenever the 100% oxygen comes into picture, we always think about the pulmonary and CNS toxicity. This is the model, we use it in our hospital. This is the panel view, this is a manually operated, now computer operated is also there. This is always there is a nursing staff which will be sitting inside along with the patient in our chamber in case of any emergency. Till date, we have not faced any critical emergencies during the session, because we started this facility 8 years back in Trivandrum. This is a mask through which the patient takes a one-way valve. Through one side the oxygen goes in, and through the other side the exhale carbon dioxide, and which will be delivered outside the chamber, not inside the chamber. These are the higher authorities which regulates the indications, especially the UHMS based in the USA, and the European Paramedical Society and the German Society. They give the indications. These are the indications approved by the UHMS. These are the primary you can see conditions like air gas embolism, carbon monoxide poisoning, decompression sickness. These stages, this is the primary modality of treatment. If you subject an individual, the individual will survive. And two more condition is high altitude pulmonary edema and high altitude cerebral edema. The items which I had highlighted in the blue color, that is healing of problem wound, necrotizing tissue infections, refractory osteomyelitis, these are the indications we use more in our center because our center is a trauma care center. This is an upcoming area that is oncology. Most important thing is you can use it for a lot of mandibular osteoradionecrosis. You can use it for cyclophosphamide or the radiation use, hemorrhagic cystitis, and you can use it for the vesicular cutaneous fistula following the surgery in malignancy patient. And the Amartha Institute of Kochi is doing a lot of research in the field of the use of in glioblastoma multiforme after the resection, how it will prevent in the recurrence. These are the current trends. There is always a debate about these things. I will pay few seconds for this. The post-traumatic brain injuries. If you subject an individual as early as possible, the traumatic brain injuries will give a good response. And autism, it is always a skeptical area to cover, but certain studies promotes the use of HPOT in autism, but from my experience and my colleagues' experience, I think it is not it won't give a dramatic improvement in autism patient. Cerebral palsy, always again debatable. There was Neubar has described that it is very useful because of the theory of whenever there is an injury happens to the brain, there will be deposition of the idling neurons around the periventricular area. Whenever you give an oxygen, it will take up its function, but it is always, the RCTs are not that favorable in the use of cerebral palsy. The post-anoxic encephalopathy, hypoxic ischemia is a very good area. And I think in the next 5 to 10 years, this will be the area of interest. By rehabilitation of sports injuries, it started way back in 2005 when during the IPL, the first Dale Steyn has been rehabilitated in Indraprastha Apollo in the chamber about 17 years back, 15 years back when the IPL was going on, and it is very useful in sickle cell crisis. The contraindications, you should not submit any patient who has got a history of a pneumothorax or a bulla, you should not submit him. And other things are related to upper respiratory infection because he may have a barotrauma or ear pain which can occur, and high fever and claustrophobia. But nowadays the chamber is designed in a beautiful fashion. The claustrophobia factor you can eliminate completely. Side effect, the middle ear trauma, the sinus barotrauma, and reversible myopia. This entity is very rare if you use it for, restrict up to the use of pressure of about 2.5 ATA. If you go above 3 only, there is a chance. This is what my job is today, to make you all aware about these things. These are the problem wounds we come across in our day-to-day practice. Basically, it is because of the tissue hypoxia. If you can resort to any system which can overcome the hypoxia, we can do wonders to the patients. This is our data 2 phase of study. It is expected to be published soon because there was some issue with the ethical clearance. Now it has been, after the COVID, we are stuck with the communication. Now we are cleared and we are expecting a soon publication. And in the last 8 years, we had treated more than 2,600 patients of different etiologies, mainly the wound issues, and there was no unwanted event, and average success rate was somewhere around 70%. This is how we classified the wounds, which was fully granulated, partially healed, and those patients who had not completed about 10 sessions of treatment, we had categorized them under the dropout category. You can see that in the 2 phases, average number of patients was about 210, and around 20% of patients came to us with a history of a small, means a regional amputation, that may be a disarticulation of toes or something. POD was very high in that, and diabetic ulcer was a major etiology in almost all the groups. So you can see the pre-TCPO2 level was about 30 to 35, and the post-TCPO2 has gone up to 55 to 60, and that may be the reason the patient's wound has been shown a dramatic improvement, and the Wagner stage was the leading group, the stage 3 was the leading in etiology. And no improvement was almost seen in about 9 cases, and majority of the cases was suffering with an osteomyelitis with a Charcot arthropathy. This is the average number of sessions in our study, which has shown that about 23 will be ideal. The TCPO2 improvement, as I said, there was an average increase of 22 millimeters of mercury has happened. This was the one amputated limb which has been advised for BK amputation. He had come to us. You can see this patient is doing, there is no recurrence for last 2.5 years with the wound. This is a necrotizing fasciitis. This is still, he is undergoing treatment, 10 sessions over. I think you can see the fully sloughed tendo Achilles. Now the granulation has covered the tendo Achilles and he is doing well. And this was again a critical limb ischemia following an RTA. and we had given the HPOT, and he had, after the some orthopedic procedure, I think he is completely doing it. He was a driver, now he has shifted to a shop worker. This is again an interesting finding we have seen in diabetic foot osteomyelitis. It is a very useful modality of treatment. This, we had presented it in DFSI conference last year. The clinical utility, the patient who was included in the study was about 130. You can see all these patients who has been not referred to the improved by the standard modality of treatment, which has been referred to us only subjected for HPOT in this study. And basically the duration of diabetes was very high, about 50% was showing 10 to 15 years of duration with a high incidence of peripheral arterial disease. You can see the clinical presentation. The ulcers with sinus is leading the chart, and the clinical and X-ray evidence was about 45% patients it was positive. You can see the inflammatory parameters before the treatment, and it is coming down, and the renal function also improved. Probably it may be because of the improvement in the treating the infection that has given a positive result. This was again the gram positive organism, negative organism was leading the chart in the osteomyelitis group, and about 63 patients has completely healed from this study. And this is articles which is promote the hyperoxia will promote the bone healing because it will promote the osteoblast function, and it will increase the strength of the bone also. This 10 years back we had published this. This is a case series study of how we can use HPOT in cyclophosphamide-induced cystitis. I think it is a very wonderful modality of treatment. Still it is used all over the world, and it is an accepted indication. This is again, as I said, necrotizing fasciitis or necrotizing soft tissue infections will respond very fast, and it will give you a wonderful result. And this Fournier's gangrene, this has been responding very well, especially in diabetic patients. This is a upcoming areas, that is inflammatory bowel disease, especially in ulcerative colitis or inflammatory bowel disease. This has resulted in healing of fistula and all other complications, which is not responding to the traditional modality of treatment with the steroid and the other drugs. This is an interesting case which we had faced in last year. This was the first reported case of type 2 decompression sickness completely treated in any civil hospital in India. I'm mentioning about civil hospital, not military hospital. This was a fire safety officer. He had a decompression sickness reported to us in a comatose state. He has been completely recovered after the 7 days of treatment with the SPOT. This was the international recognition. We got it in the Diabetic Foot Society Gulf meeting and UNDAS update for our work. And this is the upcoming age. A lot of people, you may have heard about oxygen parlors and other things, how this will prevent an aging process. So a lot of studies are coming up. We know that there is an oxygen paradox which is playing a role in the age. So if you improve the promote and hyperoxia, there will be more chances of the anti-inflammatory damages which is happening into the body. And you can see when you subject an individual to hyperbaric oxygen therapy, the stem cell stimulation which will be improved, the angiogenesis also will be enhancement, and there will be alleviation of inflammatory response, especially the interleukin 6 and interleukin 8 cells. So this will help us in what you call the proper aging or promote our aging process. It has been shown by the studies that the insulin sensitivity will be improved. There will be, the beautiful finding is that the cognition is very much improved if anybody is subjected to SPOT, especially that is what it has been used in cerebral palsy. But this is always a critical point. I think RCTs are not that in favor of using HPOT in cerebral palsy, but still a lot of people are using it. Maybe something is better, maybe based on the policy, something is better than nothing. And refractory mucormycosis, we had few patients, especially during the COVID time, because of this high incidence of mucormycosis, and again it is shown a good response. And this is the area which is coming up significant, that is tumor hypoxia play a central role in many malignancies. And if we can target the tumoral hypoxia, I think there will be a lot of good results, especially you can use it in, as I said earlier, the breast cancer, the mandibular region, the head and neck cancers, the colorectal cancers, and the brain tumors. Because this is the ORN study which is very useful in osteoid necrosis of mandible HPOT. And we had 6 cases of calciphylaxis, and it is a very difficult condition to treat because of the constant dialysis and the intractable pain. I think patient has a lot of improvement. At least they will get rid of their pain, intensity of the pain will reduce. This is again traumatic brain injury, as I said earlier, because time is running, I'll just rush through. This is a study again conducted in Kerala. I think it is in Amrita Institute, it is Snake Envenomation Tertiary Care Center. They said that there is a less need for what you call wound debridement, and whenever they applied the graft or flap, it has been taken up. This again the heel pad avulsion. These are the facilities which is available. I think there are nowadays about 15 to 18 centers are there all over the India in private sector, but the majority is used in the military setup. So I think the next few years will be the oxygen revolution, and these are the articles or the academics which if anybody wants, you can read it. And the most important thing in this hyperbaric medicine is you have to assess the quality and you have the quantity of SBOT, and you have to balance it and you have to use it based on your clinical experience. So when we fight a battle like non-healing wounds and problem wounds, I think proper timing of the weapon is very important. You can't use your best weapon as the last resort when you are fighting a battle, otherwise you will lose the war. So it is not entirely impossible that someone in the next decade, the professors of medicine will have a difficulty in explaining why treatment with oxygen was not widely accepted much earlier. I will stop here with this statement. Once again, thanks for Anuj sir, Murthy sir and Srivastava for this wonderful opportunity. Thank you all. Have a nice day. Jai Hind. Any questions, I will be happy to answer. Yes, sir. Yes, we are always there in Trivandrum to give hope. Thank you.
Very nicely covered, beautiful presentation. Just a small thing, we are short of time. What about burns?
Pardon, sir?
What about burns? Burns.
Burns actually it is very useful because most of the problem is the surgeons have a hesitancy to send patients for a SBOT. I don't know why, maybe professional issues. But what I don't know whether you have heard about a Puttingal temple blast which has happened about 5 years back in Kerala during the festival season. We have treated a lot of patients. It will help you to get rid of that contracture, which is especially the major problem in burns patients, especially if it is at second degree or
because once they get infected, it becomes very difficult to manage.
It is a wonderful if you give before putting a graft or a flap, or even after, it will increase the success rate.
And I totally agree with you, and I think I'll share this opinion of yours, which is very relevant. The most clinicians refer their patients when everything else has failed.
Yes, sir.
So I think they should be the standard of care in the initial period, which is very relevant because then the recovery rate is very high. Once again, thank you for a wonderful
Thank you, sir.
talk.
Welcome, sir. Yes, sir. Yes, INS Ashwin. Yes, sir. Yes, that's what. Yes, sir. We have certain pre-check because we will allow only cotton drugs. Cotton dress, they should not use any perfume or oil on the hair on that particular day, and not in full stomach. Yes, sir. Yes, sir. Yes, thank you, sir. Thank you.
Thank you very much. And for the next session, we have a very wonderful session now in this segment. We are going to be discussing challenges of aging population in India. I think it's increased lifespan. We are all facing this challenge. And to invite for that on the dais, I would be happy to invite Dr. Mohammad Reyes, whom you are already aware of, to deliver this talk. Welcome, sir. And as you can see, it's a big introduction. I would not do justice if I were not to complete everything, but because of paucity of time, he is a professor of medicine and the director and chief consultant at Isani Diabetes and Multi-Speciality Center, Hyderabad. Besides his MD medicine, he's done postgraduate diploma in diabetology. He's running the postgraduate program in diabetology, and he's also got a diploma in family medicine affiliated to RCGP diploma in endocrinology. He's got multiple international and national level publications. He's authored multiple books, Thyroid Made Easy, Clinical Medicine and Endocrinology Made Easy, which I would like to have a copy of, something which I love to read. He's been a joint secretary for RSSD at Telangana chapter. He's an early career physician council member. He's an executive member for RSSDI and ISCCM. He's holding multiple fellowships, fellow of American College of Physicians, fellow of International Medical Sciences Academy, and fellowship of Indian Association of Clinical Medicine. And he's been awarded, including the Star Asia Award and Vaidya Ratna Award, and the list goes on and on. So I won't come between you and his achievements. And welcome, dear Mohammed, for your wonderful talk. We are patiently listening for you. Thank you very much.
Thank you for your kind words, sir. At the onset, I would like to thank Anuj Maheshwari sir, Narsingh Verma sir, as well as Murthy sir for organizing a fantastic meeting. I think last 2 days were academic feast. The last is the burden for everybody. Now I think as the age is advancing, we have challenges of aging. Now I think you have read the newspaper day before yesterday itself. Now India would be becoming the #1 country in terms of population as well as aging. So there are challenges which we have to face it. Now what is basically aging? Aging is nothing but it's an accumulation of the molecular defects throughout the life, and it causes repairs, that is the multiple defects as well as multiple repairs and maintenance mechanisms which are going on, and it leads to impairment that could be functional or in the tissues or organ. Now there are various aging names which are being extrapolated. I think everyone knows about active aging, and there is a gerontology, that is basically the study of the physical and psychological changes which are incident to the age. You know that there is a preventive geriatrics which is going on in the talk of the town. It is nothing but the art and the science of preventing the disease in the geriatric population and promoting their health and efficacies. Now you know that what are the challenges in terms of the access and affordabilities. You see, the population is increasing over a period of time, and the percentage of the people who are increasing at the age of 60 years is almost tripling. Yeah, I think it's correct now. Now you see that the number of the population which is increasing in the elderly is almost like 2.5 million elderly people. If you see it from 2005 to 2010, and it is expected like by 2025, it would be almost 158 million, which is a staggering number. Now why I say it is a staggering number, because you see that elderly patients are more prone to complications and the non-communicable disease, which is a health hazard. Now you see, out of the 7.5% of the elderly population, 2/3 of the population live in villages, and half of them, if you see it, they live in poor socioeconomic conditions. That means the affordability to the healthcare and access is very poor for them. Now what we have to do it, we have to get an affordable healthcare access for these people where they can get appropriate treatment. Now if you see the burden, the southern states over the last decade were predominant in elderly population, but north is catching towards the south, and they are matching towards the proportion of the north and the south in terms of the elderly population, which has been studied in Alam and Karam et al. In 2010. Now if you see the morbidity and the mortality patterns based on the age, you see that elderly population suffer from majorly cardiovascular disease, circulatory disease, and cancers, whereas in non-elderly you see infections and parasitic diseases are our major health burdens which are there. If you see in developed countries, the non-communicable diseases are the major culprit for it, but whereas in developed countries, in developing countries, the communicable and non-communicable are responsible for all the complications. Now if you see, Indian elderly populations are more likely to suffer from chronic complications than compared to acute, because of modernization and healthcare system which is being now improved over a period of time. Now if you see the rise of non-communicable diseases in terms of cardiovascular, metabolic, degenerative, as well as other communicable diseases which has to be taken care. Now you see multiple chronic diseases in elderly, right from chronic bronchitis to anemia to hypertension to coronary artery disease, as well as the kidney ailments which are there, and digestive problems which was addressed by Dr. Mohsin and Dr. Bharat Sabu will also be speaking about it, as well as diabetes, which is the talk of the town, and rheumatism and depression. Now depression, I think over a period of time has been increasing due to multiple problems, and that has to be addressed and that has to be taken care. Now what are the things which are changing with the aging and it is causing a clinical impact? You can see the slide is pretty crowded and you can see each and every organ is affected with the aging, and we have to address all these things. If we don't address right from the cardiovascular system to the toe, that is, we can see that every complications from head to toe, right from the central nervous system to the peripheral vascular disease, everything could be involved. Now, if you see the aging, what are the aging and what are the things which can contribute to it? It is environmental factors, genetic, lifestyle, and psychological. These all play in hand in all in aging. Now, if you see what are the categories by which we can categorize, it is basically the biological factors, mental factors, behavior factors, nutritional factors, and socio-economic factors plays a very, very important role. Now, if you see the approach to presenting problem in old age, you see there are several issues at the same time which the patient presents to you, and you have to address multiple problems at one go. So those could be in the form of delirium, incontinence, and falls, such as if you take it. Now, what we have to do is we have to approach systematically an elderly patient. The first thing is to obtain a collateral history. That is very important. Second thing is we don't have time, we don't check all the medications. That's very important. You have to check what the medications the patient is taking, as well as any changes which has been undergone for the medications have to be seen appropriately, as well as search for and treat for acute illnesses or any other comorbidities which is there, and reverse the predisposing factors which are there. Now, if you see the major problems which we are facing in elderly populations are four things. The first thing is the fall. Second thing is the delirium. The third thing is urinary incontinence. The fourth is ADRs, that are adverse drug reactions, and dizziness, which is very commonly seen by all of the practitioners. Apart from it, you can see other problems which are there in terms of hypothermia, undernutrition, infections, fluid and balance disturbances, heart failure, hypertension, diabetes mellitus, anemia, and as well as rheumatic diseases. Now, what is fall? And as per WHO, the fall is being defined as an event which results in a person coming to a rest inevitably on the ground or the floor or other levels. Now, if you see the fatal fall rate percentage as per the age and the gender, you can see very clearly the age between 85 plus and above, there is an increased tendencies of the fall, and the percentage, if you see in comparison with the men versus the women, the men has a higher percentage than compared to the women. Now, if you see the age-related osteoporosis, it is a dramatic rise in the hip fractures and other fragility fractures that occurs with the aging. Now, if you see the fall, it leads to loss of confidence and fear. That is very important to address. Now, where should we do the medical attention, and what is the need of the medical attention? 20 to 30% are mild to severe injuries, and underlying cause of 10 to 15% of all emergency visits which are there, underlying cause should be addressed and underlying things should be addressed. And if you see 50% of the injuries are related to hospitalization, and they require hospitalization, which are seen predominantly in the people who are age of 65 years or older. Now, if you see the hip fracture, traumatic brain injuries as well as upper limb injuries are very commonly which we see in our clinical practice. The problem is they have longer stay, and if you see it compared to other injuries, there is a longer duration of stay in the elderly patients due to comorbidities as well as the other associated fractures. Now, if you see in terms of hip fractures, the hospital stay is extended by almost 20 days, and older patients are predominant to succumb to the illness due to multiple comorbidities, infection, and if they have diabetes and other cofactors. Now, if you see what are the post-fall syndromes, that is, one thing is dependency, the second thing is loss of autonomy, the third thing is depression, fourth is confusion as well as immobilization and restriction in the daily activities. Now, if you see the risk factors right from the intrinsic and extrinsic factors, which are very clearly, the extrinsic factors are the floors, the materials which you use on the floors, as well as other factors plays an important role in external contributing factors. Whereas internal factors, I think I have said just before, in terms of the medical burden, mortality-based, acute reversal process, and chronic diseases are very clearly shown, like it can lead to increased incidence of the fall. So what is the risk factor model, which very, very clearly says it depends on the environmental factor, behavior factor, biological factor, as well as social factors. Now, if you see the causes of the fall in elderly patients, right from the accident to environmental related to gait disturbances to drop attacks to confusion, the postural hypotension, as well as syncope and other unknown causes are there. Now, if you see the risk factors, in terms of the balance defect as well as the weakness contributes to the higher list than compared to the other parameters. Now, how do we assess the fall in elderly patients which are aging? The first thing is to identify the high-risk individuals. That is very important. The second thing is the history of the fall. That means any previous history of fall should be anecdoted, and it has to be taken care, because if we miss it, then definitely these patients are more prone to recurrent hospitalizations to the recurrent falls. And details of the frequency, surrounding circumstances, and injury severity has to be taken into consideration. There is a scale which everyone commonly uses in terms of the fall, which is basically FROPCOM, that is basically falls risk for older population in community care. It covers between 13 risk factors in almost 26 questionnaires which are there. Now, if you see the sensitivity and specificity, it's almost between 66 and 65%, which is there. But practically speaking, I don't use much of this single task performance in my clinical practice. Now, if you see other single task performance which are there, the important thing is everyone can see how the posture of the patient when he enters into the OPD of yours, or when he's brought to the ER, you can just have a postural ability of the patient as well as the physical performance. The second thing is that it is very simple, easy, and it doesn't require much time, and it's a single domain, and you don't require higher-end machineries to just demonstrate a simple task performance which is there. The second thing is FTSS, that is 5 times sit and stand on the chair rise, which has to be done. This is a predictor for the recurrent falls, which is very important. Now, if you see the time up and go, basically it is in individuals with falls are slower than the non-fallers, where it has been proven by Shwane and et al. In 2000. Now, if you see the multitask performance, which is a comprehensive approach to the falls assessment, but it is time consuming, and it is incorporating multiple systems which has to be addressed into it. Now, if you see, there is a score which is assessment score which is done. This is called as a POMA, that is the performance oriented mobility assessment, which can be done, that helps to know the inter-rater reliability as well as the ability to differentiate between the fallers and non-fallers. Now, if you see how do you prevent it, the prevention is very easy, like you have to do physical therapy approach. It could be multi-component approach exercise, a benefit which is there, or whole body vibration training, or home hazard assessment should be done. That is very important. Now, what has to be done apart from the exercise? The calcium and vitamin D tablets can be given for the patients, and by evaluating properly what is the other causes. And home environment assessment, and you have to address the home environment, the factors which are predisposing to the fall, as well as modifications which are required has to be done. And if you see, the medication review has to be done, because medication review is not done very commonly, that has to be addressed. And if a patient is having a cataract where the vision is the problem and that could have resulted in the fall, you have to see that the cataract surgery could be a possible, and anti-slip shoes as well as cardiac pacemakers for carotid sinus hypersensitivity can be used. The second most common problem after your fall is your urinary incontinence. What is urinary incontinence? What we see in elderly aging population, it is involuntary loss of the urine. So when it is addressed, when it is severe and it is causing a social or hygiene problem, only then it is addressed by the patient, and they turn up to the doctor. Now, if you see it, it is seen in all age population. It is more prevalent in the older age population, and it affects 15% of the women and 10% of the men above the age of 65 years. This is a very clear-cut approach for an elderly patient who is having an urge incontinence. If they are having associated pain, hematuria, recurrent urinary tract infections, or any your suspected fistulas, you have to address the need. If it is not, then this can lead to multiple problems. And you have to assess the patients who are having urinary incontinence, and if the patient is having urge incontinence or significant postvoidal urine, or your stress urinary incontinence, if it is addressed properly, then definitely the patient can be relieved from the problem. The common burden in elderly population is the prescription of the medication, and we should learn the art of de-prescribing. We are notorious, and we are very fine to do the prescribing, but we don't see the poly-prescriptions which are given by the multiple doctors. Like now we have subspecialties available. Each practitioner would not see a predecessor, what he has written it, and they just write the medication. We have to see, we don't give a polypharmacy for the patients. So what is polypharmacy? Basically, it is the use of 4 or more drugs. When we use it, is called as a polypharmacy. So polypharmacy, it leads to, it is very commonly in elderly population. It is due to multiple pathologies which are there in elderly population. population, and a poor patient education. The patient is not aware what for he's taking medications, how long he has to take medication, and what for the indication has been given. That education has to be given to the patient. That is very important. The third thing is the lack of the routine review of all the medications, because it's a time consuming and everyone is a busy practitioners having a full loaded of OPDs. So the routine evaluation of all the medications what the patient is taken is not done appropriately. If you see the patient's experiencing expectations on prescription is very common in Indian subset of population. When the patient goes to the doctor, he expects that the miracle should occur with a one prescription or within a day or two, whatever he takes the medication. That's the major problem. Overuse or drug interactions or interventions by the doctors plays a very, very important role. Attendance of multi-specialty clinic, which I have said just now, plays a very, very important role in polypharmacy also. And poor communication between, that is interdisciplinary, interspecialty, the approach should be there, where the communication should be there, or there should be an access of the file which could decrease the pill burden and the polypharmacy which is there. Now, what are the common adverse drug reactions in older patients? If you see it right from the NSAIDs to diuretics to warfarin to ACE inhibitors to opioids and anticholinergic, it's very clear like each drug has untoward event and you have to address it. And if you don't address it, then definitely it can lead to multiple problems. Now, what is deprescribing? Regular review of medication should be done, and you have to deprescribe as early as possible. Second thing is, if the patient's medications are causing untoward events or side effects, it should be deprescribed. And you should ascertain why the patient is being given that drug, and if the problem is solved, then that's definitely deprescribing of the medication has to be done. So what has to be done is you have to ask your patient to get all the medications and all the prescriptions, at least whatever he is taking, and see that whatever the relevant medications are there, continue it, and irrelevant medications should be weaned off. That is very important. Now, in elderly population, you see there is one more issue, that is hypothermia. Hypothermia exists when the body normal temperature and body normal temperature regulatory mechanisms are unable to maintain the heat in a cold environment and a core temperature which falls below 35 degrees. So moderate hypothermia is less than 32 degrees centigrade and severe hypothermia less than 28. So age-related associated changes can lead to impairment in vasomotor function, skeletal muscle response, and sweating. So it means the older population react more slowly than compared to younger population. So you have to address other comorbidities if the patient is having like atherosclerosis, hypothyroidism, or any medications which are altering with the thermostatic center. Now, if you see, based on the different degrees of the temperature, you can see the different problems which are there, and you have to address right from the mild hypothermia to moderate to severe, and heat exhaustion and heat stroke, which is well known to every practitioner who is sitting here. Now, what are the investigations what we have to do in an elderly population? If they are suffering with hypothermia, blood gas analysis should be done. That's important. Complete blood count, electrolytes, and X-ray, which is very important, apart from the ECG, which is routinely done for hypothermic patients. Hemoconcentrated and metabolic acidosis, which are there, has to be addressed, and it has to be addressly treated. ECG, if you see, it shows classical J waves, which is very important to know, and these patients are notorious to develop arrhythmias, which could be cardiac arrhythmias, including ventricular fibrillation. Serum aspartate amino acid, creatinine kinase may be elevated, and secondary to muscle damage, which is there, and amylase is oftenly high in these patients, and additional investigations, if required, has to be done. Now, if you see, the management mild hypothermia is sheltering the patient, and you have to just rewarm the patient. That is commonly which is done. In severe hypothermia, you see you have to restore the perfusion as well as rapid reforming has to be done. Apart from it, in certain cases, ECMO can also be utilized. That's extracorporeal membrane oxygenation. Now, the most commonly, which I think every practitioner who see the elderly patient coming to an ER department in a delirious or acute confusion state, which is common in 30% of older population, either admission or during the hospital stay. And it could be associated with increased mortality and morbidity, and it requires a longer stay. You see that the etiopathology, it could be multiple etiopathological things. And if you see in terms of the risk factors, the old dementia, alcohol misuse, severe physical illness, friability, polypharmacy, and renal impairment could also play an important role. Now, if you see, this is a clear-cut how to address the need of the delirium, right from the infections to metabolic to your toxic screening as well as hypoxia, which can lead to multiple problems in terms of delirium. And you have to address the delirious patients. Acute management could be in terms of a small dose of haloperidol if it is required, or benzodiazepines can be used if the alcohol withdrawal. And if you see it, the rehabilitation also plays a very, very important role. What are the rehabilitation techniques? It is important is education, encouragement, listening, advice, and hard intervention. These are soft intervention, and hard intervention in terms of medication, physiotherapy, and occupational therapy, and speech and language therapy. So it's a teamwork. You have to address all this team. And these are my take-home messages. The elderly patients are having high mortality and morbidity, and key access healthcare has to be addressed, which is very important to be taken care in Indian elderly population. Health affordability should be the priority for everyone, because if affordability is not there, definitely these patients may not turn up to the appropriate medical care, and they may land up into complications, and they may come up to the ER in the severe bad shape where they may require a higher stay, or the mortality or morbidity risk is increased. I conclude. If any more questions are there, I'll be delighted to answer it. Thank you, sir.
You can ask the question.
Thank you, sir.
Former President, RSSDI. Thank you, sir. Over to chairpersons. Kindly invite the next speaker.
Okay, now for the next session, only a few housekeeping rules. See, the opening batsman and the closing batsman both have their problems, and we are running at the end of the session. We are short of time, so I would appreciate if the speakers keep to the time limit. And there is a special memento prize for those who finished before time, actually. So they are encouraged to finish before time. So first of all, I call Dr. Bharat Sabu, and he is the chief diabetologist and director at Indore, and he has got a long list of accomplishments and awards. I think it will be by the late evening before we finish the list.
Thank you, sir, because it will hamper my prize.
Yeah. Thank you. So over to you. Okay.
A very warm good morning to all of you, and I'm really thankful that you are here in spite of the late night event yesterday and so beautiful beach outside. And I would like to thank ACP, my elder brother, Dr. Maheshwari, and I would also like to thank Dr. Narsingh Verma sir, Dr. LSM sir for inviting me here. And it was their constant push which brought me here. Actually, to be very frank, I was having a family function, and they are the one who brought me here. And again, I am thankful to Dr. Narsingh Verma because I'm a hardcore diabetes technology man, and he has given me a topic which required a lot of hard work out of me to prepare it on management of chronic diarrhea. So without taking much of your time, and as sir has promised me a prize, I will be sticking to my time. And actually, to begin with, chronic diarrhea is actually defined as a loose or watery stool which occur 3 or more times within 24 hours and lasts for 4 or more weeks. Because it is a very common problem, 5% of population suffers from it, and most of the episodes in developed countries are acute and self-limited and usually due to infections. But ours are little different. But in immunocompetent patient, acute infectious diarrhea typically resolves within 4 weeks, and in immunocompetent in developed countries, chronic diarrhea is generally not infectious. So this is actually a very beautiful review which I found regarding perspective in clinical and gastroenterology and hepatology. It is by American College of Gastroenterology, and it clearly defines the differential diagnosis of chronic diarrhea, which is a long list because we all know it can be watery, it can be fatty, and it can be inflammatory also. So how can symptom clusters and setting focus the differential diagnosis? I like to make this talk a little more practical rather than talking all what is given. So the main distinction in patients with chronic diarrhea is between functional and organic etiologies. And the functional categories include IBS when abdominal pain accompanies the diarrhea, and functional diarrhea when abdominal pain is absent. So IBS can be prospectively characterized by symptoms such as those defined by the Rome 4 criteria. And again, there are certain symptoms which can prompt us regarding the diagnosis, because it is very important to take a history from a chronic diarrhea patient. Abdominal pain, fever, or GI bleeding can suggest an inflammatory cause. Gas and bloating can suggest a carbohydrate malabsorption. And even our patients on metformin and acarbose complain the same thing, so we should look for that. Substantial weight loss can suggest malabsorption, maldigestion, or malignancy. Fatigue and night sweat should prompt you to look for lymphoma. Anemia or change in stool caliber suggests colorectal malignancy. A recent history of traveling should prompt you for protozoal strongyloids and tropical sprue and traveler's diarrhea. And a history of constipation should prompt you to look for an overflow diarrhea. And patients with diabetes are those who are attempting to lose weight. This is very common these days. You should look for their diet foods. Are they consuming anything which is causing diarrhea to them? Now the red flags are there in terms of symptomatology. We should be very wary of these things. These are painless diarrhea, a recent onset of diarrhea in an old patient, nocturnal diarrhea, especially if it wakes up the patient and he goes to the loo, weight loss, blood in the stool, a large stool volume, more 400 grams if we can quantify by any means, I don't know how. Anemia, hypoalbuminemia, and increased ESR. These are the all red flag signs which should warrant investigation in our patient. We should not wait. Then how can clinician distinguish IBS from other causes of chronic diarrhea? This is very interesting. The Rome criteria provides the framework actually for diagnosis of IBS and emphasizes pain and other etiologies also should be sought when these criteria are not met. And patient without alarm feature, as I have told you the alarm feature, who meet criteria for IBS should be treated without further testing. And one meta-analysis suggested that prevalence of CD in patients meeting criteria for IBS was more than 4-folds that of the control without IBS. Now these are the diagnostic criteria for irritable bowel syndrome. As I have told you, Manning and Rome 3 criteria. And Rome 3 has symptoms of recurrent abdominal pain or discomfort. Pain is relieved by bowel movement, and onset of pain is related to change in frequency of stool and change in appearance of stool. So now moving forward, what is the role of diet? Because I have told you about the diet to be looked upon and how it can cause the chronic diarrhea, because there are specific dietary components that may cause or aggravate chronic diarrhea. A careful dietary history is definitely a must for any patient with chronic diarrhea. And true food allergies are rare causes of chronic diarrhea in adult. We are always prompted with food allergies, but they are usually the rare cause of chronic diarrhea in adult. Now, in considering association with food, we should consider substances that in sufficient quantity cause diarrhea in normal gut, that is fructose, and that can cause diarrhea because of an underlying condition. A condition is there and we are eating it and that is causing diarrhea, such as dairy product in lactase deficiency, or the gut alteration that limit digestion or absorption, such as short bowel, pancreatic insufficiency, and other things, and idiosyncratic food intolerances, which is very common these days. People are not tolerating certain things, like wheat, many people are not tolerating, so it can be a cause. And the identification of a dietary cause is only facilitated by a food diary. You need to ask patient to maintain a food diary, and he should record what he has eaten and the frequency of stools, and that will solve most of the purpose if it is food related. Now, lactose is a very common cause of diarrhea, and it is a very common cause of diet-induced diarrhea. Worldwide, most adults are lactose intolerant, and they are gradually becoming vegan and avoiding dairy foods. And the fructose, which is found in certain fruits, actually it is naturally not in a level which can cause diarrhea, but fructose is present in corn syrup, which is very commonly used as a, I would use the word adulterant because I don't like this molecule. So it is very commonly used to mix with anything, and that is a leading cause of strikingly increased fructose intake, which causes diarrhea. Sugar alcohol malabsorption, sorbitol, mannitol, xylitol are poorly absorbed, and they also cause diarrhea in many patients. Now, gluten intolerance. It should be mentioned here because it is a very common cause, And the diagnosis of Crohn's disease is based on symptoms, serology, and intestinal histology as well. Now, it can present with a wider range of symptoms than it was previously appreciated. There are gluten-responsive symptoms, which we all know, which are present even in absent serology. Serology is negative, but gluten symptoms are there. And patients with chronic diarrhea should be screened for Crohn's disease, if possible. Then, fatty and fried foods frequently are implicated in pathogenesis of diarrhea and other symptoms. Food allergy or immune reaction, which can cause diarrhea, as I've told you. And 1 to 2%, this is rare, but 1 to 2%, 100 in 1 or 2 have, 1 in 102, sorry, can have food allergy. So we should look for it, and frequency is higher in children. Now, what medications are common cause of diarrhea? Because there are more than 700 drugs which have been implicated as causing diarrhea, accounting for approximately 7% of the adverse effect. And this is a list which I have cut short, and these are the most commonly used drugs which can cause osmotic, secretory, motility, malabsorption, and even the pseudomembranous enterocolitis also. So these are the molecules which are there and implicated for diarrhea, and we all know about this. And what are the other therapies which can cause diarrhea apart from medication? When we look to it, there is a radiation enteritis, because radiation, we all know, causes up to 20%, of the extent of 20%, those patients who are treated with pelvic irradiation, they suffer from diarrhea. And the risk factors are low body mass index, prior abdominal surgery, if there is any comorbidity, radiation dose if it is too high, fractionation and technique, as well as the concomitant chemotherapy. So this is to be looked upon when we are looking for a chronic diarrhea patient. Now, post-surgical diarrhea is also very common, which is common after vagotomy, bacterial overgrowth, bile acid malabsorption, and short bowel syndrome. This is all we know, and actually this is a common culprit post-surgery for a chronic diarrhea. Now, when a diagnostic testing is indicated, let us see. Testing should be done in the presence of alarming features, as I have told you. If there is an alarming feature, the list which I have given you, when differential diagnosis can be effectively distinguished on the basis of test result, and when the differential diagnosis remains broad and initial testing will limit the number of additional tests needed, we should go for testing. And for disorder without definitive diagnostic test, we should go for therapeutic trials. This is a recommendation. Now, is there any benefit from categorizing chronic diarrhea, like we used to categorize chronic diarrhea into various modalities? What is the actual benefit? When differential diagnosis is broad, so stool testing is a measure which can characterize diarrhea and can direct further evaluation, which would be more precise. And the chemistry test of stool can be used to categorize diarrhea, and it should be considered when the diagnosis remains obscure after the initial assessment you do. So fecal lactoferrin, calprotectin, and it can be used as a surrogate measure, and stool chymotrypsin and elastase have some utility. So characterizing diarrhea type in given patient should allow a more focused differential diagnosis, and your vision will become much narrower and you will be able to diagnose it much better. So there are various subtypes of diarrhea, you all know. We all know that there are 3 major types of diarrhea: fatty, watery, and inflammatory. And we begin with history taking, as I told you. We categorize based on the stool appearance, and if it is fatty, then we exclude anatomic defect. We do radiography, sigmoidoscopy, colonoscopy, and exclude the pancreatic insufficiency. We do the stool chymotrypsin level. If it is positive, confirm with secretin test. A positive result confirms pancreatic insufficiency, and if it is negative, we should explore for other diagnosis. For inflammatory, we do the stool analysis. Positive for blood or white cell. If it is there, we do the fecal calprotectin level. If it is positive, we confirm the inflammatory bowel disease. If it is not, we go on exploring the other causes. And if it is watery, we see for the fecal osmotic graph, which is, if it is high, we consider it as osmotic. Then if we ask patient to fast, if fasting improves it, we discuss the diet history. Diet history again becomes very important here. If diet related, perform breath hydrogen test. If it is positive, confirm lactose intolerance. And if it is, the fasting is not improving it, we should explore other diagnosis. Now, when the osmotic gap is normal, diet modification is what is needed. If it improves, fine, we need not do anything. If it does not improve, we should do a celiac panel. If it is positive, it is celiac disease. If it is negative, we should again explore other causes. And if the osmotic gap is low, it is secretory diarrhea. We should do a stool analysis. We should exclude anatomic defect. We should do selective tests which are required. So now what is the utility of blood tests? Because blood tests, they provide the clue to etiology. Again, they give us the status of the fluid and electrolytes. And that other blood tests should be obtained when demanded by the clinical presentation. We should not write every test whatever is available. We should be very judicious based on an elaborate history to prescribe only those tests which are actually required. And hormone secreting tumors, I will tell you, are very rare causes of respiratory diarrhea. So we should be very wary while writing all those tests. First, we should exclude other causes and then move on to that. So because of rarity of peptide secreting tumors, measurement of circulating peptide level should be reserved for very selected patients. This is what the guidelines say. And in patients with classic tumor syndrome, evidence of tumor or severe chronic diarrhea that remains undiagnosed after a detailed evaluation, measurement of serum chromogranin, gastrin, vasoactive intestinal peptide or calcitonin level, and urinary 5-HIAA can be considered. So this should be reserved after excluding the other causes. So what is the utility of imaging actually? The imaging studies are useful in patients where steatorrhea and secretory or inflammatory diarrhea is there. So they define the anatomic abnormalities, they delineate the degree and extent of inflammation. This is what they tell. They can diagnose chronic pancreatitis and they demonstrate hormone secreting tumors also. So in patients with steatorrhea, abdominal CT or MR scanning is done to assess for chronic pancreatitis. Plain radiogram you can do for evaluating the colon transit and the possibility of overflow diarrhea. And hormone secreting tumor can be assessed by CT scan, preferably the multi-phase helical CT scan. PET scanning can be used in some patients, again very selectively. So what is the role of endoscopy, enteroscopy, colonoscopy, and mucosal biopsy? Now lower gastrointestinal endoscopy, colonoscopy with biopsy is valuable for microscopic colitis, IBD, neoplasia, and other inflammatory condition. While upper GI endoscopy, there is relatively little information regarding role of upper GI endoscopy in chronic diarrhea, but esophagogastroduodenoscopy and duodenal biopsy can confirm a diagnosis of CD. So upper GI endoscopy again provides an additional diagnostic methodology beyond visualization and biopsy, including duodenal aspiration for giardia. This is only which I was able to found. Now what is the role of physiological and microbiological testing? So bread test can assist with diagnosis of carbohydrate malabsorption and SIBO, and idiopathic bile acid malabsorption may be more frequent than previously appreciated, but there are no specific tests, so empirical therapy is the only option which is available if we are suspecting that. And direct pancreatic functioning again is not widely available, so we test it indirectly. And then again we go by radiographic measurement to test and look for the pancreatic abnormalities. What is the approach when the initial effort failed to make a diagnosis? In spite of doing all these things, you have done all these things and you are failing to make a diagnosis. Now what should be your approach? The failure to make a diagnosis is more likely due to overlooking a common cause. Mind it, if you are failing to make a diagnosis in spite of doing all this, you are not dealing with something which is very gruesome, but maybe you have missed something very simple. This is actually the thing. And physicians should repeat the history again, right from zero, physical examination, and review the studies already done before ordering any additional test. And repeat testing should only be done with the cause. If they are very sure about it, they should go for a repeat testing. Now, what empirical treatment can be used for symptomatic management? Now, empiric management is needed when testing does not find a specific diagnosis. We are not able to find a diagnosis even after doing everything, and when a specific diagnosis has no specific treatment or a treatment has failed. So we use the empirical therapy. Opioids are the first choice. They are effective and safe. We all use loperamide, and it is a mu receptor agonist, we all know. It slows the intestinal transit time and increases the net absorption. And like all opioids, actually, it slows it. So all the opioids share the same. But why we use it? Because it has minimal penetration into the brain. That's why it has a little potential for abuse. So in chronic diarrhea, scheduled dosing is what is most important. We schedule the dose of patient. For example, if diarrhea occurs after meal, before meal dosing is used, and morning predominant diarrhea, if it is there, the dose should be given at bedtime. This should be kept in mind. This will improve the outcome. And there are various opioids also which are more potent, but we don't use due to its abuse potential. And potential for abuse is a serious concern when we are using an opioid for our chronic diarrhea patient, because he can use it chronically. So it can be minimized by informing patient about risk of abuse, by starting with the low dose and titrating the dose gradually upwards, and by refilling prescription only when anticipated volume should have been used. You should be very cautious with these things. Now, bile acid binding resins are effective in bile acid malabsorption. Neither antibiotics nor probiotics are useful as non-specific therapy in chronic diarrhea. But I will counter this with my next slide, because this is a US guideline which is there, and I have something to show to you. Clonidine is an alpha adrenergic agonist drug. It simulates absorption and slows the intestinal transit and may be useful in diarrhea of opiate withdrawal. When we withdraw it and diarrhea is there, we can use it. Anticholinergic medication used to treat other conditions may mitigate diarrhea, so they can also be used. We can also use octreotide for small volume watery diarrhea and fecal incontinence. Fiber supplementation or a hydrophilic poorly fermentable colloid may be helpful. And we also use soluble fibers such as pectin, which increase the viscosity of luminal content. Oral calcium supplement, if we are giving to our patient, may help in chronic diarrhea, because they also help, along with bismuth subsalicylate, which is also frequent OTC, which helps in chronic diarrhea. Allosetron is also there. So there are a lot of things which we can use by our judiciousness, and actually there is no simple and logical algorithm to govern the empirical therapy. Therefore, a thoughtful trial and error approach is frequently required to find the most effective therapy or combination of therapy for each patient. So if we are lucky enough to make a diagnosis, we can treat it in a proper manner with the given diagnosis. But if we are not able to make a diagnosis, then empirical therapy is only the way out. And this is actually a thing which, thanks to Dr. J.K. Sharma, which I came across. And this is a rectally administered E. coli for acute distal ulcerative colitis, and it gives us very good result. So the take-home message is chronic diarrhea is much more common than we think. History remains the integral component in our management, and we should not forget the food diary. We should use the investigations judiciously, because there are n number of investigations. There is no simple logical algorithm. Trial and error is the only way for empirical therapy. And failure to make a diagnosis is more likely due to overlooking a common cause rather than searching for a rare cause. Thank you.
Thank you, Dr. Sabu, for completing this very lengthy topic in a short time. But I'm sorry I can't nominate you for the prize because you didn't finish before time. And okay, next I call upon our final speaker.
I will try next time, though. Thank you.
Fall upon the last over of the match, you know, I called Dr. Nishant Kanodia to please give his deliberation. The prize is open for you also if you can finish before time.
I'll try my best. So, respected chairpersons and I have esteemed guests, I'm here as the last batsman for the meeting for ACP Vizag. I'll be talking about diabetic foot ulcers. Very recently, one of our guest speakers have talked about diabetic foot ulcers, and the talk was for SBOT also. So we had update that we had done a publication for around 300 patients post-COVID in avascular necrosis of hip, and they were treated with HBOT. Everything should not be given to the surgeons, and medicine is a very strong branch, and many things, many complications like the foot ulcers can also be treated with medicine. So the topic for today is fungal infections, diabetic foot. So any infection involving the foot with the patient who has a diabetic, has a chronic injury or injury of the soft tissue, can have neuropathic or ischemic diabetic foot, and that can convert into diabetic foot ulcers. Over 415 million people are with chronic diabetes, and they may rise above 640 million by 2040. So ulcers are one of the most common complications of people who have diabetes. So a person with diabetes has a lifetime risk of developing a foot ulcer by 25%. And every 20 seconds in the world, statistics, patients are getting amputated of the lower limb because of the foot ulcers. So diabetic foot ulcers that extend to the bone are the main cause of lower extremity amputations, and they are an increased risk of mortality and morbidity with the high cost burdens. So the epidemiology is that from the North India, 1/3 of the patients diabetes prevalent are having peripheral neuropathy. 2/3 of these patients were at risk of ulcers, and 9% of these people are prevalent ulcers, out of which 20% requires amputation. The prevalence of diabetic foot infections is estimated to be 6 to 11%, and the neuropathy is considered to be the most important determinant for the occurrence of the infections of the diabetic foot infections. The diabetic foot infections may include infective ulcerations, known as malperformance, paronychia, cellulitis, myositis, abscesses, necrotizing fasciitis, septic arthritis, and tendinitis. How to identify the risk of diabetic foot infection? A history of 10 years or more of diabetes, previous foot ulcers, or lower extremity amputation, poor glycemic control, impaired vision, and some structural abnormalities of the foot like calluses, hammer, claw toes, flat foots, and biunions. The pathogenesis most likely involved of the chronic ulcer is peripheral neuropathy, peripheral arterial disease. It can be both and the low immune system. Coming to diabetic neuropathy, long-standing diabetes can cause the nerve damage in the form of tingling sensation, pricks and needles, burning sensations, numbness, increased sensitivity that may be increased by the risk of cuts, sores, or blisters. So if prompt treatment is not given for the infection, they may lead to ulcers and even gangrene. Peripheral vascular disease is because of diabetes that leads to the change in the blood vessels, including the arteries in the peripheral vascular disease. The treatment usually affects the blood vessels in the extremities of the hands and the feet and lowering the blood flow. So poor blood circulation can lead to pain, infection, and wounds will heal very slow. The symptoms, again, may be blisters, loss of sensation, numbness, red streaks, with or without draining, painful tingling sensation. If the infection in the person is developed, then he or she may have fever with high blood sugar, trembling, shock, and redness. So the neuropathy and the peripheral vascular disease are the severe conditions that need proper medical care and follow-up, because both will cause foot ulcers, infections of the skin, bone, and abscesses, gangrene, and foot deformity. Charcot foot is the shape of the foot that is altered due to the breaking of the bones inside the foot or the shift of the toe is shifted. This is the Wagner's classification for diabetic foot ulcers, where the grade 0 has no ulcers, grade 1 involves the superficial skin only, deep ulcers is grade 2, grade 3 is having deep ulcer with cellulitis or abscess, grade 4 is localized gangrene, and extensive gangrene with the whole foot is grade 5. So diabetic foot ulcers are the combination of predisposing risk factors like the sustained hyperglycemia in a normal foot can cause to abnormal immunity, leading to angiopathy, micro and macroangiopathic systems that will lead to ischemia and edema. Other can be triggering factors of intrinsic and extrinsic type, motor, sensitive, and autonomic neuropathies. They all lead to diabetic foot ulcers, and aggravating factors like previously non-healed infections that can also lead to diabetic foot ulcers. In real-world studies, approximately 15% of all the infections are caused by fungi, and invasive fungal infections are increasingly day-to-day that may cause sepsis in uncontrolled diabetic patients, and patient may may finally land into as a critically ill patient in ICUs. These are the symptoms of the fungal infection: irritation, scaly skin, swelling, blisters, and it could be because of mold, yeast, tinea. The stages of the fungal infection could be 3. The areas of small redness and cracks at stage 1. Skin of the foot or toe begins to peel off, stage 2. And there is a separation of the skin that is visible from the wound, and this is stage 3. So tinea pedis and onchosis are the 2 major fungal infections of the foot. So within the general population, tinea they are coexist, and 15 to 20% of the incidences are happen in diabetes. These infections disrupt the skin's integrity and provide a avenue for the bacterial superinfection in elderly diabetic patients with dermatophytic infections that can be promptly treated with an antifungal agent. Coming to tinea pedis, it can be of 4 types: Trichophyton rubrum, interdigitale, Epidermophyton folluscum, and microscospum. So the fungal infection can contribute to the development of the pathogenesis of ulceration and cellulitis in diabetic foot in number of ways. It could be because of complication due to infections in an already dry foot or autonomic dysfunction. In the cases of loss of protective sensation associated with diabetic neuropathy, they may result in the fungal infection. The patient will be unaware of that infection. Because of peripheral arterial disease and vascular insufficiency, they reduce the tissue viability and protection of the damage. These could be the fungal infections that can be present: tinea capitis, fasciae, barbarae, copperis, manum, ungum, curis, and pedis. Coming to onychomycosis, thickening of the nails as a result of onychomycosis may result in the increase in the subingual pressure and the subsequent ulceration, and the nail begins to break on the epidermal surfaces, and they dig into the skin and the irritating toes, creating ulcerations. Candida is one of the commonest infection of the fungus that is present. It contributes almost 5% of all those cases of sepsis. Candida accounts for 70 to 90% of the invasive fungal infections, and aspergillosis almost 10 to 20%. Candida is commonly found in throat, gut, vagina in healthy individuals, but Candida yeast can be the cause of infection in the compromised immune systems like diabetes. Candida is emerging serious global health threat for not only being difficult to treat, but also difficult to identify. There have been some studies in India, like in Bhubaneswar, where the primary objective was to find out that why the diabetic foot ulcers are getting infected, and the secondary objective was to detection of the fungus. In this slide, you can see that majority of the fungal infections are contributed to Candida species, and second is Trichophyton species. There is another study that has also demonstrated that Candida albicans should be at the top of the table, followed by Candida glabrata and Candida tropicalis. So the relationship between the fungal infection of the feet and the cellulitis of the lower extremities in the people depends on the type of the infection and how bad the cellulitis or the infection is. A study was done with 243 cases of cellulitis and 467 control subjects, and they were found that the infection rate was significantly higher with cellulitis than in controls. Another study of 100 patients were done with mycosis of the foot with 200 controls, and analysis of the fungal culture demonstrated positive relationship between dermatophyte infection and cellulitis. Literature also signifies almost the same syndromes. IDSA guidelines given in 2004, 7 and 12 had said about uninfected, mild, moderate, and severe infections associated with these problems and fungals. So management of the fungal infection of the diabetic foot involves these 4-5 majority of things. Maintaining a good foot hygiene, so you have to wash your feet daily, dry especially between the toes. Feel for any bumps or temperature changes, look for the toes and check each toenail. Each toenail should be straight, and there should not be any cracked skin. Examine the bottom of the feet, track whatever you find. These are some of the emollients that are usually prescribed: chlorotrimazole, terminofen, in the oral form or maybe in the ointment form. Shoes. It should be very important to wear shoes because you are working all throughout the day, and the shoes are the most important part of your diabetic foot. The shoes should be without heels or narrow toes. Shoes should keep your feet dry, and old shoes should be replaced as soon as possible. Socks. When in the communal areas, individuals should avoid direct contact with the floor by wearing flip-flops and never wear the other people's shoes. So benefits of diabetic socks are that they prevent dry feet, reduces the infection, reduces the pressure, reduces the irritation, and gives the better circulation to your feet. Stop putting your feet in the germ-filled stinky shoes, so you can disinfect, and these type of disinfectant modules are available in the market to disinfect your shoes. Blood sugar control is very important. Whatever you do, if your sugars are not controlled, your fungal infection won't go away. So vigilance in managing the blood sugar can prevent a whole lot of complications that will go well beyond the fungi. These are the general measures. Keep your feet dry. Try to kill the fungus. Avoid yeast infections. That begins with the balanced diet and proper hygiene. Avoid sharing the items like towels, sports equipments. Wear breathable fabrics. Athlete food often can be treated by topical antifungal ointments. And severe infections can require oral medications also. This is the specific treatment. Dermatophyte infection needs terbinafine. 1% can be applied once or twice daily for the skin, and for the nail, it's required in oral dose of 250 milligrams once daily for 3 to 6 months. For nail infection or non-dermatophyte molds, oral itraconazole therapy is required as a pulse therapy. So people are majorly resistant to the treatment, or there is a role of polypharmacy that makes it difficult to maintain a good foot hygiene and to remove the fungal infections. These are the different types of fungal infection, fungal treatments that are available in the form of azoles and amphotericin B. Newer treatment option is ozone, which is used as the antimicrobial, antibacterial, and antifungal purposes. Amputation due to fungal infections is supported in the literature. This is one clinical case scenario in which patient was patient was a diabetic, HbA1c 8.3, and got ulceration of the first and second row. Culture sensitivity as short staph aureus, was sensitive to flucloxacillin. 2 weeks of the course was given 4 times a day, foot settled, but things reoccurred. The patient again came, and the skin scrapings was sent, and in conjunction to flucloxacillin, fluconazole once daily was also started. After 2 weeks, flucloxacillin was discontinued, but due to ongoing interdigital irritation, the fluconazole was continued. So when to seek the medical help? Color changes on the foot, swelling on the foot, temperature changes in the foot, constant sores in the foot, pain or tingling sensation in the ankles, in the groin, toenails, athlete foot or any fungal infections, dry or cracked skin, or any sign of infection you see. So you must seek a medical help. My final thought, diabetes and its complication never show a way to recovery and until diagnosed and managed early in life. Poor compliance and negligence to anti-diabetic therapy give rise to foot ulcers and fungal infections very soon. Oral antibiotics and antifungals are the guidelines. Directed treatment should be tried first before initiating any intravenous fungal therapy as per the IDSA. See your foot as you see your face in the mirror daily to avoid diabetic foot ulcers. Preventive skincare is vital to your comfort and the long-term health. Keep an eye out of the skin changes, and that could indicate the fungal infections. And early intervention can prevent more serious complications. So give your feet a happy feet and happy you. Thank you.
Thank you, Dr. Nishant, for this comprehensive coverage. And you since you have finished before time, I'll nominate you for the special memento for finishing early.
Thank you, sir. Thank you, sir.
With this, I think you close the session. There's no question on session because it's the final over, and you can discuss over lunch.
This was the last presentation, and now we are heading towards the valedictory function. And the valedictory function is basically for the attendees, the presenters, and delegates. So, in this function, I invite your comments. Those who are here, they can come here and give their comment, what they feel about this conference. The idea of this conference was generated 1 year back. Since then, we are active, trying to find out how we can arrange the things and how the scientific program can be formulated. And very well in advance, about you can say in the month of April, we were able to find out the scientific program in general, and April onwards we started sending the invitation to various presenters so that they can present their topics, because all the topics were new and they were not the old topics, and ready-made slides was not there. So enough time was given for all of them so they can prepare it and present. So I invite all of you who want to say something about the conference. This whole 3-day conference we started on 18th, 19th, 20th. So anybody who wants to say something is welcome here. Yes, sir, please. यहीं से बोले? हाँ.
Thank you, Dr. Verma. You see, I am from Bangladesh. came on 17th. First thing, it became difficult for me to know the program. I did not get the schedule, the topics from the beginning, because most of the conferences we get it before. Then when I came, I saw every day the schedule is giving. This is a different, maybe different form of idea. There is something behind it. Regarding this arrangement, I'm so delighted to say you, so thank you. And the topics, all topics I enjoyed. And see, I came here every day at 9 a.m. I stay here up to 6 or 7 p.m. I have done most of the topics as I could cover. Crossed there, come here like this. So speakers were so nice and their deliberation was very helpful to me. Thing is, I was looking for an abstract summary because in our place we try to give a book. Even I went DCDC, they gave book. Even I go Speedicon, they give book. Even in Calcutta, they give book. But here we did not get any abstract summary book. I think next time you will remember it. Lastly, suppose I am here today. Now it is finished. My flight is tomorrow afternoon. This 36 hours I will be sitting here without anything. You know, everybody of us is busy. We have busy schedule in our life. Not only for me, for others. So if I could know this, it will be finished today, now I could live today. You know, see, BJAC has very little aeroplane connection. You cannot get the schedule of the plane. So I must request you to invite me again, and I will be delighted to come here to attend this seminar. Same time, please let me know or let us know when we can schedule our arrival and departure. Thank you, everybody. I have listened to many of you, and all of you are very brilliant in presentation. Thank you very much.
Thank you, sir, for coming all the way from Bangladesh, and your suggestions have been well noted. Just I wanted to explain something that in India, what we have seen, we spend a lot of money on books, and most of the time, when delegate left the conference, books are lying in the conference room. They never carry it. It is also true for ADA. In ADA, you will find a very voluminous book, but all delegates leave that book in their room. It is difficult to carry. And today, I have seen that most of the conferences, instead of publishing any abstract book, what they do, they publish it e-book or e-abstracts. So your idea is good. We will think over it. Thank you very much, sir. Anybody else want to say something? Because valedictory functions always for the delegates, for the attendees, for the faculties, and all those who have attended it for 2-3 days, and now they want to express something. Dr. Balkishan Gupta is associated with us since very long, and he usually comes in most of the conferences and attends very seriously. You can give another mic, or you can come here.
Thank you, Narsim Verma sir. It is your cordial invitation and your affection, Dr. Anuj sir, Dr. Narsim Verma ji, and Dr. Amit Gupta. Their affectionate invitation forced me to come over here. I am Dr. B.K. Gupta, working as Senior Professor Head, SP Medical College, Department of Medicine, which is at the border of Pakistan, far away from this place. It took nearly 24 hours to come from that side to Bikaner, to this Visakhapatnam. But I forced to come here because of their cordial invitation. And that is not a waste, because I learned a lot here from basic practice back to the basics. This is very important nowadays, because we are just looking at the technology, looking only for investigations, what our PG students are doing. Pain abdomen, go for sonography, go for CT scan. But we are forgetting about basics. So this is very important message from this conference to all the PG students, that they must go along with technology to the basics also. This is very important. The scientific deliberations were very high class, very nice. And research presented here, they are very up to the level. And I think so many PG students, they presented their work. Even MBBS students, junior students, they presented their work in very nice way. This is very much encouraging to us as a teacher. So I think, and most importantly, what I see in many conferences, that very little attendance is there in the lecture theater, when the presentations are going on. But in this conference, I saw that all of the chairs almost they are filled. So this is very good that the presentations were very high, and they all are persons. They are interested to learn something from this conference. I again must thank Dr. Anuj Sharma sir, Dr. Narsingh sir, and Dr. Amit Gupta ji for their very nice organization of this conference, and and the organizing secretary, I forgot, and the organizing secretary ji, he met me when I just landed here. He also affectionately told me and welcomed me. I thank everybody and everyone for their participation. Thank you very much. Thank you very much, sir.
Thank you, Professor Balkishan Gupta ji. Sir, you want to say something? Please pass mic to him.
Good morning, everybody. I am Colonel Devda, retired. I have been alumni of FMC Pune. I did my MD in 84. I am practicing medicine for the last 40 years, and I am a member of APA also, and I have attended so many APA conferences. And being a diabetologist, I have attended so many other diabetes-related conferences, including IDR. But what I found here, one thing is, there is the involvement of youngsters here. Youngsters are being encouraged to, speak on the podium, like presenting papers. Their best theses are being, presented on podium. And no time is wasted. The main thing is there is no waste of time. Right from 9 o'clock, the academic activity starts and it continues till 8:30 or so. And all the subjects were very contemporary, very relevant, and speakers chosen were also par excellence. And we have heard them so many times at other forums also. Now, with this thing in mind, I have decided to take membership of ACP. I was discussing with Dr. Narsingh this morning, and I would try to get a fellowship also. So, wish me good luck. Thank you so much.
Thank you, sir. And I may now I can reveal, when sir was asking to me at this age whether I go for the ACP membership, then I said, sir, age is not a bar, and age is only in the mind. And still you are young, and you are teaching, you are working, research, and also attending all the patients. So it will be useful for you. And sir has agreed to take membership. Anybody else want to say something? Before I invite our members and our vice president and others to. So now, before. Yeah,
Thank you, Dr. Verma. I am Dr. Ajay Kumar Pandey from Varanasi. I am a practicing cardiologist and a faculty member at Heritage Hospital, Heritage Medical College. Though it was my first meeting here, but I am really excited to see the topics which were put in here, and the basic aspect which has to be learned by all our youngsters, which you have pointed and made it here. The only suggestion from my side that there are plenty of sessions were there, and there are a lot of intermixing of topics. So if the sessions will be divided, like diabetology session is one, which will have all the diabetology talks. If the cardiovascular session is one, or nephrology or obesity, that will make a better choice for people, those who want to be more specific in that area.
Thank you, sir, for your all guidance and all suggestions. But my humble submission is that, my personal thinking is that, when we go and divide the things in cardiology, nephrology, neurology, we miss most of the things. When we become super specialist, our vision becomes tunnel vision. And a physician is, the same physician is also seeing the patients, and patient may have some neurological problems. For every neurological problems, he may not refer it to neurologist. So he must know his boundary, when to refer. So your suggestion is well taken, sir. We will try to do divide it in various sessions next time. Anybody? Now I call upon Dr. Vasant Kumar, sir, most senior person, and he is past president of RSSDI, to bless us with his knowledge, and then I will invite our council members.
Good afternoon, friends. So we all had wonderful time together for the last 3 days. You know, it's a mixture of academics learning from each other, meeting friends, and learning so many things apart from academics itself. What is great about this conference, Dr. Narsingh Verma, is that apart from the academic science and research, there are a lot of other approaches towards our holistic management. You know, like many people, even this morning we had a topic about olden aspect, the ancient medicine. Yesterday, Dr. Muruganathan spoke about so many things, how the patient needs to be addressed by us with the empathy, and so many things. It's actually, and also ACP is a part of an international organization, so whatever we do, it perlocates down to rest of the countries, and it's so happy that we had faculty from Bangladesh, and wonderful commitment by the governor and Dr. Narsingh Verma, and a lot of my young friends. I can see Amit here, Anup, and a lot of you. I mean, it's finally the commitment that helps us to grow the organization. That is exactly what all of you have. I congratulate all of you, and thank you for making me a part of this. Thank you. Thank you.
Thank you, sir. Now I will invite my council members, and first of all, I will like to invite Dr. Ajay Tiwari to come here and say a few words. He was helping us behind the scene since very beginning. So a few words from Dr. Ajay Tiwari.
Thank you, sir, for giving me this opportunity and making me the part of the team. And I am a big proponent of a good team, and I think that I am the last man in that team. And I'm so happy to work under your inspiring leadership. So our governor is a very dynamic person, and he leads from the front. And he has got so many ideas. He is always brimming with ideas. And Professor Narsingh Verma, he is a man of excellence as regards to the scientific commitment. The entire scientific program reflects his impression, his thought perception, how to do the things, and more on assimilation. Medicine is just not about talking about the different aspects, neurology, dermatology, and all those things. It's all about how we make a cohesive approach. So I think it is very well reflected in the scientific program prepared by Professor Narsingh Verma. I thank you all for coming in largest numbers, and I think in a valedictory session, so many people attending, it's a great, great feat. Thank you very much.
Thank you, Ajay. And you are saying the correct thing. Suppose a patient of diabetes comes to you and he has developed some rashes. So you will not refer every patient to dermatologist. You will try to find out whether the rashes are because of dry skin, or because of the season, or because of some drug, sulfur drug, which sulfonylurea patient is taking, or because of DPP-4 inhibitors. A dermatologist may not know that DPP-4 inhibitors can cause the rashes, but a diabetologist should know. So now the scientific program, it was possible only because of the help of Dr. Anubha. So I will call her to say a few words. The whole scientific program, she is scientific secretary. So whole scientific program was prepared by both of us under the guidance of Anuj Maheshwari, the governor, and other council members. They guided us. Anubhaji, please.
Thank you, sir. It was my proud privilege to work under the leadership of our governor and dynamic Dr. Anuj Maheshwari sir and our dynamic scientific chair Dr. Narsingh Verma sir. I've learned a lot, and I am so grateful to all the delegates and our faculties who came across in spite of all the odds, reaching here and attending in so much numbers and liking the scientific content. And thank you for making it successful by making such topics very sincerely and presenting deliberately. For anything which has been amiss, we request you will be able to correct and rectify in the subsequent conference. Thank you.
Thank you, very rightly said. We will correct ourselves if some deficiencies are there. And now I call upon Saurabh Srivastava, our council member, to say a few words. Dr. Saurabh has been active in so many fronts, and he is our helping hand in most of the times. Professor Saurabh Srivastava, please.
Thank you, Narsingh Verma sir. It was my privilege to have this conference, and the scientific program is such a mix that it gives an impression of what is being thought of by our Governor Anuj Maheshwari sir, Narsingh Verma sir and Anubha, that it has been crafted so well that every topic was a new topic, and it was not a simple topic to be presented. The topic was to be framed, first learned and then presented. So, and they were all practical aspects of working during the working of a physician, whatever cases we see and all that. So these things are so good that, and that is what is reflected in the audience. Still the audience is present. So everyone is here to learn, and this conference has made a big impact. Thank you.
Thank you, Saurabh. And very practically said by Dr. Saurabh that every faculty was forced to learn and then present here. Now I invite the dynamic person who has helped us a lot since the ACP working, since very beginning, Dr. Amit Gupta, please.
Thank you, sir, for this opportunity. And we all know that the conference has been a great success. And the ACP India chapter is growing leaps and bounds under the able leadership of Dr. Anuj Maheshwari, Dr. Narsingh Verma, and all the governing council members, and all the members of the ACP. So at this point of time, sir, I would like to take this opportunity to request each one of you, if you are not a member of the American College of Physicians, then please become members, take the membership of the ACP. The ACP membership comes with a host of benefits. Yes. And becoming the ACP member is very easy. You can visit the website, or you can speak to me just after that, and any of the governing council member would be able to help you. You can go to the website and immediately you can become the member. And the membership of the ACP is an annual subscription based. So I will request, if you are already a member, then please keep your membership in good standing. That is very, very important, because if you wish to advance to the fellowship, if you wish to do other activities, it is very, very important if you keep your membership active. There are a lot of things which we can always talk about. ACP is the only body which I can say that which is active throughout the year. So it is not just the annual conference. Every week you will find a different program. So there is a ACP India case files, there is ACP well-being programs, there is ACP women's health program, there are a lot of studies. So if any one of you wants to become a member, and if you wish to be active member of the ACP India chapter, then simply write to the governor, and you will definitely be accommodated, and you will be given a chance, because this is an inclusive society, which I have seen over the period of last 2 years. So with this, I would like to say that please keep your membership active. If not a member, become a member. Keep following ACP at all the social media handles, its website. Now the new website of the ACP is there. You will get all the information. So you simply visit acpindia.org, and you will find all the information regarding the American College of Physicians. Thank you, sir.
Thank you, Dr. Amit Gupta. Now I call upon most senior person, our Vice President, Dr. J.K. Sharma, sir. He will also tell you what are the benefits of becoming a member, apart from his address. Dr. J.K. Sharma, sir.
Thank you, Professor Anuj Maheshwari, our Governor, ACP India chapter, Dr. Narsingh Verma, all the people sitting here. You know, success of any conference is by the number of delegates attending the conference. And second thing is that the number depends on what is the scientific content. Because in today's world, lot of conferences are going on. So the delegate will stay in the conference only if the scientific content is very great. And we can see here, even in the last lecture, there were lot many people sitting here. Hall is practically full. So all credit goes to Dr. Narsingh Verma under the leadership of Professor Anuj Maheshwari. And of course, as mentioned, Dr. Anubha Verma has been instrumental in taking it forward, in executing it. So thank you, everyone. Now I come to the another point regarding the membership. I am a fellow of all 4 Royal Colleges of the American College of Physicians, American College of Endocrinology. What particular we see in the American College of Physicians? Anything and everything related to medicine, if you want to learn, if you want to see, explore, just visit the website. Everything is given there. And when you become a member, please keep your membership active. Then only it is possible to progress to the fellowship. We all have observed yesterday regarding Dr. Anuj Maheshwari, how to connect with people, how to keep them bind. Because we have never seen such good attendance at such a distant place. Because he has the power, he has the capability, and he has the zeal to connect everybody, to involve everybody. And this we have seen. So be a member of ACP if you are not. The student membership is free, and we all are in a stage to afford the membership, to continue the membership. So don't consider that it is an annual membership, annual subscription is to be taken. We all are well off for this academic purpose. So with that, I thank you everyone. I thank you all the advisory council members on behalf of our governor and on behalf of all the people working here from the ACP. Thank you very much, sir. I can see all the senior members, people from international Bangladesh. So with that, thank you. And I invite you all for the next year's conference. The venue and dates will be decided and will be informed to you all. Thank you, sir.
Thank you, sir. Now I invite all the council members on the stage for the award which has been left or which has to be, which has been decided. All the council members, Dr. Ajay, Saurabh, Anubhaji, I think she has left. Fine. Okay. So, in the invited podium presentation for best publication presentation has already been given yesterday. Only one prize, Dr. Jigyasa Gupta was not present at that time. So I invite her, Anubhaji join kariye. Dr. Jigyasa Gupta to come on. नहीं ठीक है Okay, next free paper session, BC Roy Hall. Free paper session in BC Roy Hall. We have winner, Dr. Rohit Jacob. Rohit has been awarded yesterday as well. He has got so many awards. And first runner-up in this is Dr. Tanvi Borse. Dr. Tanvi Borse. So only shawl नहीं उड़ाएंगे, वो अच्छा नहीं लगता है। Second runner-up, Siddharth Gosavi. He has again won so many awards. Siddharth Gosavi, I think is not here. No problem. Now, free paper session, William Osler Hall. First winner is Kashish Malhotra. Kashish Malhotra, he is here. He is here. Are? And first runner-up is Dr. Divendu Bhushan. Dr. Divendu, I think he has left. He has left. And second runner-up is Dr. Anjan Yadav. Yeah, Arjan Yadav. Free paper session. Any conference is known only by free paper presentations, research paper presentations, not by faculty presentations. Because faculty presentations are only cut and paste, while the free paper presentation is his own presentation. Best Thesis Award has already been given yesterday. And now coming to physical e-poster. For physical e-poster, winner is Swaraj Vadarkeri. Swaraj, I don't think he's here. First runner-up is Sasrul Ingavele. Ingavele. Sorry for pronunciation because it is difficult to pronounce your name. I have to practice for pronunciation. Good. He told me it is Susut Ingavale. So Susut everybody can pronounce? Yeah. These names will be put on the website as well. Second runner-up is Rohit Jacob again. Rohit has got so many awards. Rohit award. So again Rohit. For virtual free paper session, I can announce, because it was virtual, they can't come here. Their medals, etc., will be posted to them. Virtual free paper session, first session, Asjit Kumar Dang, he was winner. And Hirday Harimohan, first runner-up. And Vikyut Satish, second runner-up. We can clap for them. And virtual e-poster, the first position was by Justin Cornelis and second by Pankaj Singh. So these were the winners, and this will be put in the record also on the website. So that ends the award. So with this, I think we have not left anything. I will invite our Vice President J.K. Sharma sir to formally say vote of thanks to all of us. all of you.
So, every good thing comes to an end. And here we are at the last minute of our conference. So, on behalf of ACP India chapter, we are thankful to, first of all the delegates who have come to attend this conference from far places. Special thanks to all the postgraduates, all the students who have taken out time to come here, present their work, attended the conference. And then we extend our heartfelt thanks to all the faculty, the speakers, the chairpersons, the panelists, the moderators, and our concept conferences who has been our management partner. So thanks to them, thanks to all the pharma industry educational partners, because without whose help it would not have been possible to conduct and carry out this scientific program successfully. Thanks to the hotel industry where we have been there, the hotel people have been very kind. And to all the people who have supported us, our cameraman, our videographer, everybody and anybody who has involved physically, emotionally, financially with this conference of ours in making it a success. And with that, I am not thanking my own team because it is our duty to do that. But as a customary, I extend my heartfelt thanks on behalf of the governor and myself. Thanks to all of them. So with that, we end and everybody is invited for lunch. Thank you very much. Have a safe journey back home and carry good memories with you. Thank you.